A very good morning to all of you, all the dignitaries, the guest of honor, the speakers, and all the participants. Come from the GAI Foundation, and this is Manisha, and I'm the principal of Radiant Institute of Physical Sciences. I'm going to moderate today's session. So I would like to welcome to all the speakers for the day, and I would like to introduce one by one to everyone. And today's guest speakers are Dr. Girish sir, Nita ma'am, Dr. Prakash sir, Dr. Lekha Bist ma'am, Dr. Dr. Sandhya ma'am. She is a guest speaker for the day, and we will see whether our guests have arrived or not. So for the today's session, and the first session will be taken by Dr. Girish sir. Dr. Girish sir.
Yeah. I am there. Am I audible?
Yes, sir.
Yeah. Shall I share my PPT?
Yeah, sure, sir.
Yeah, I'll do that.
As before continuing your session, Girish sir, I would like to introduce all the members to you. As Girish sir, he is a associate, he is a professor in Yanapova University, Mangaluru, and he has several years of experience, and he has many books and articles, and he has attended many of the national and international conferences. And recently, I think sir has presented one paper in some international conference, sir. So, Girish sir, he is a very renowned person from the nursing background, and it's over to you, sir.
Yeah. Am I audible?
Yes,
The
sir, but
slides are
voice is
visible.
little bit low, sir.
Slides are visible. Just 1 second.
Yes, sir.
Slides are visible.
Yes, the slides are visible, sir.
Problem with the audio? Hello.
Yes, sir.
Am I audible now?
Yes, sir, you're audible now.
Yeah. Good morning, everyone. Respected chairperson, distinguished speakers, honored guests, esteemed colleagues, ladies and gentlemen. It is indeed a great privilege and honor to be with you today. I sincerely thank the conference organizers, scientific committee, and session chairs for inviting me to speak on this important topic. It is always inspiring to be a part of an forum where experts from different countries come together to exchange ideas that can improve global health. Hello. Today, I will be presenting on a topic called as Transforming Global Health, Recommendation for an Healthier World, a framework for action in 2024 and beyond. This presentation is based on current global evidence and mainly focuses on the practical recommendation that can strengthen the health system and improve the health equality worldwide. You all know that health is one of the greatest investment any nation can make. You also know that whichever country is having an healthy population, they always contribute to the economic growth, they always contribute to the education, innovation, as well as sustainable development of a country. Even despite several scientific advances, are certain millions still they lack access to the basic health care. You all know that the COVID-19 pandemic reminded us that challenges, they do not respect any boundaries of any country. Doesn't see whether a particular country is economically very rich and the other country is very poor. It is our collective responsibility. It's important to build resilient and equitable health system. You all know that the WHO estimates that at least half of the world population still does not receive what we call it as essential health services, making universal access to one of the important and greatest global priorities. I also invite you to think beyond your own healthcare system, okay, and always consider what global collaboration can achieve. Before discussing solutions, let us first understand why transforming global health has become an urgent global priority. You all know that global health has never been more important than how it is relevant to today's society. Although you know that healthcare has improved tremendously the past few decades in certain countries, the world still continues to face a lot of unprecedented challenges happening nowadays, in spite of all the greatest achievements what we have. One of the greatest examples for that is COVID-19 pandemic, which has exposed the weakness in even the strongest healthcare system, such as it can be your United States, United Kingdom, and all the developed countries like China. Also know that there is a lot of climate change that is happening. Nowadays in India, even it's a rainy season, feel like it is summer. Climate change is creating a new health emergencies, including heat stress, and there is a lot of infectious diseases that is spreading everywhere, and there is always a sense of food insecurity. Another important issue what we are facing is population aging. As population is aging, it increases the burden of chronic diseases. You also know that world is undergoing lot of conflicts and displacement. These conflicts and displacement continue to affect the healthcare delivery worldwide. There is always what we call it as health inequality. It is one of the important aspects what we need to address, or it is one of the greatest challenges what we are facing in the 21st century, called as health inequality. You all should remember that health is no longer only a medical issue. You all know that our health is closely connected with the education system, is also connected to an economics, is also connected to an environmental sustainability and political stability. All don't consider that health is only a medical issue. This health is connected with various aspects. If another pandemic occurs tomorrow, you all think for a second, are our healthcare system is truly prepared? This is a question which every nation must answer. To appreciate the urgency to reform, we must first understand enormous burden that the disease continues to place on various societies, whether it can be an advanced society or a developing society. So, in order to see the burden of the disease, you all know that disease affects much more than an individual patient. All the diseases, it influences not only the individual person, it also affects the families, which an individual is a part of an family. It also affects a community in large. It affects the economy of a country and also affects the nation development at large. Non-communicable diseases now account for most of the global death. You all know that many of celebrities, many people are dying because of the cardiac arrest and also because of other disease conditions like diabetes and cancer. Cardiovascular disease nowadays remains the major leading cause of mortality. Another important causes of mortalities are infectious diseases. These infectious diseases, they continue to grow disproportionately, and primarily these diseases are affecting low income countries. Every year there is millions of death that is occurring either because of an cardiovascular disease or infectious disease, which can be to a greater extent can be prevented. So poor health always reduces workforce productivity. Also, what it will do is it increases the healthcare expenditure. As a result, it is always important that we should pay an emphasis on investing in prevention is far more cost effective than treating a disease which is already or treating an advanced disease. You all should remember that every dollar which we are investing in prevention and primary healthcare is one of the important greatest achievement what we are doing. Any dollar you are investing in prevention and primary healthcare generates multiple times that value to increase. You all imagine the impact of every individual, what kind of impact you will have if you had an access to early diagnosis and preventable care. You would have saved billions of lives naturally if they had an access for early diagnosis and prevention. However, you all know that disease burden alone does not explain the health outcome. The other important aspect what you also need to consider is where people are living also a play major important role in what we call it as incidence of diseases. Perhaps one of the most striking realities in global health is where a person is born often determines how long he will live. This is one of the important aspect that is what happening in current world. That is primarily because of the health inequalities. Health inequalities nowadays are driven by social determinants. You know? So income, it always influences our nutrition. Income, it affects our housing. Income affects my healthcare access. Education always improves health literacy and health seeking behavior. Each and every individual, they should have an access for clean water and
तो
sanitation
क्या कहते हैं
that should
बीपी चेक कराया
always, what we call it as,
तो बीपी चेक करा
remain an essential public health priority.
कितना परफ्यूम लगा रखा है तूने
Gender inequality also
कहाँ लेके आया है
contributes
अभी जो परफ्यूम लगाने के लिए
significantly
सुबह
to
से इतना नहीं होता है
health outcomes.
रूम से जाके आया ना तो अभी रूम पे जाके
Excuse
आया ना
me, can you mute,
All the audience to kindly mute yourself, please.
please? So, health equality should be viewed as a both moral responsibility and a development. You all should remember that countries who have a strong investment in education, countries which has invested heavily on sanitation and primary health care, they consistently achieve longer life expectancy. You all do agree with me on this aspect. Healthcare always begins long before a patient reaches the hospital. Healthcare always starts in homes. It starts in our school. It starts in our community. So recognizing these inequalities will always help us to understand why health system must be redesigned around what we call it as health inequality or should be redesigned around equality. Now, having understood what are the challenges, let us now discuss the framework that can guide what we call it as meaningful changes. There are three pillars are there to support the framework. I call it as first one as universal health coverage. Second pillar is strong primary health care. Third one is skilled and motivated force. And the last one, together these three pillars, they create what we call it as resilient health system capable of responding to future challenges. Countries that invest consistently in these three pillars always, they recover faster whenever there is an health emergency, and they will also be able to achieve what we call it as long-term outcome. Now, let us discuss about the first pillar, perhaps the most important one, which I call it as universal health coverage. Universal health coverage is one of the much more, what we call it as much more than the health insurance. What do you mean by universal health coverage? Universal health coverage is about ensuring that no person suffer financially because they need some kind of help. So every individual, what they need is they need or individual deserves access to quality health care. So financial hardships should never prevent the treatment. So universal health care should promote equity and social justice. Strong primary health care is the backbone of universal health. So universal health coverage always contributes directly to what we call it as sustainable developmental goals. Millions of families are nowadays pushed into poverty every year because of healthcare expenditure. So that's why healthcare should be determined always by need, not by the person's income. But universal health coverage cannot succeed without what we call it as strong primary health care. So next one is we'll focus on what we call it as strengthening the primary health care. So primary health care, you all know that it is described as a front door of the health system. This is one of the aspects where the prevention always begins. Primary healthcare always it focuses on prevention rather than what. Three important aspects are there in primary health. One, we call it as early detection. Early detection always play a very important role in improving the survival, which can be in the form of an vaccination, which always remains one of the greatest, what we call it as public health achievements. And also, the second important aspect is called as community participation, where we are strengthening the healthcare delivery. So strong primary health care, what it will do is reduces the pressure on what we call it as tertiary hospitals, which are usually present in major metro cities. You all know that WHO estimates that strengthening the primary health care always address what we call it as majority of the person's lifetime healthcare needs. Many of our diseases, which commonly fills our hospital wards today, could be prevented through what we call it as effective primary health care. In our country, especially in India, we offer an excellent what we call it as primary health services, which are universally accessible as well as it is prevalent in a country like India, where we are giving lot of importance strengthening to the primary health care. So next one of the example of India where they are giving lot of emphasis on what called as Ayushman Bharat, which is the India's healthcare protection scheme. So one inspiring example from India is Ayushman Bharat program. What it demonstrates is how political commitment can translate into an meaningful healthcare access. You all know that Ayushman Bharat is one of the world's largest publicly funded health insurance scheme. You know, it provides financial protection for economically vulnerable families. There is an involvement of digital technology, which played a very important role in increasing the transparency and efficiency. And you all know that millions are getting benefited from cashless healthcare nowadays. This program continues to evolve with every year or with every passing year with expanded coverage. Nowadays, many developed countries are studying the success of this Ayushman Bharat model while designing their own universal health coverage programs in their country by looking at how this Ayushman Bharat played a significant role in providing health insurance for the individual. This reminds us that innovative solutions from developing countries like India can inspire global health policy. Now, having discussed about the foundations of a strong health system, let us now move to what we call it as 10 evidence-based recommendations that can transform what we call it as a global. So the next section mainly focuses on what are the recommendations that are required based on the global evidence and what we call it as a practical experiences. So no single intervention can solve we call it as global health challenges. Just one sec. Are you able to see the screen? Hello?
Yes, sir. But sir,
Okay. Hello?
yes, sir.
Okay.
It's visible.
Okay. Multiple sectors must work together. These 10 recommendations, what I am giving it today, it primarily addresses the prevention, it addresses the treatment, it addresses the importance of workforce, technology, and also financing. These 10 recommendations, what I am giving, they are interconnected rather than an independent aspect. Our government, as well as healthcare professionals and communities, all have an important role. Countries always should combine health policies with education, technology, and social protection consistently to achieve what we call it as better health. As we discuss these recommendations, I encourage you to think about which one of the recommended recommendations what I am giving will be applicable to your country or institution. Now, let us go for our first recommendation, which usually addresses one of the most fundamental requirement of healthcare, called as access to essential medicine.
Sorry to interrupt, sir, but the volume
Yeah,
is low. Could you please speak a bit loud?
yeah. Just one second. I'll just increase the volume. Just one second. Just one second. One second. Is it visible, PPT?
The PPT is visible. Your voice is little bit low, sir.
One second now. Now, and then I close it, I'll, 1 minute. Just one second. Am I audible now?
Yes, sir.
Now is it okay?
Yes, sir. It's okay now.
Yeah, okay. So the first recommendation, which is one of the first recommendation, which addresses one of the most fundamental human rights, is called as right to access to an essential medicine. Despite many countries we have made remarkable medical advances, you all know that millions of people still cannot obtain the medicine they need. Nearly 2 billion people worldwide, they lack what we call it as reliable access to an essential medicine. You all agree with me that essential medicines should always be affordable, they should be available and accessible to everyone. That is why in our country we have something called as generic medicines. They can significantly reduce treatment costs while maintaining quality. Local pharmaceutical manufacturing will also improve what we call it as medicine security and reduces dependence on imports. So strengthening our cold chain logistics will always ensure the vaccines and temperature sensitive medicines that usually reach what we call it as remote communities. During public health emergencies, especially in a situation like COVID-19, international cooperation should always prioritize lives over commercial interests. That's why one of the important recommendation, what I am telling first one is access to the essential medicine. So the the WHO lists essential medicine as one of the guide for countries to prioritize medicine that addresses the most important public health needs. Imagine diagnosing a patient correctly, but being unable to provide treatment simply because the medicines are not available in that particular country or in a community. This remains a reality in many parts of the world. You all agree with me, medicine saves life. But another important aspect is protecting the mother and children always saves the future generation. This brings us to our second recommendation called as investing in maternal and child health. You all agree with me that the health of mother and children reflects the overall strength of our national healthcare system. You also agree with me that every pregnancy should be safe and every child should have the opportunity to survive and thrive. So that's why the role of stillbirth attendants nowadays significantly what it do is it reduces the maternal neonatal mortality. So in India, what we always do is we always give importance to the regular antenatal care. This regular antenatal care, what it will do is it allows an early identification of pregnancy complications. Another important aspect in maternal and child health is nutrition during pregnancy. And you all know that there is a relationship between nutrition and pregnancy. And early childhood will always benefit from very good nutrition during the pregnancy. Childhood immunization is also the most cost effective public health. All the countries should focus on investing in maternal child which contributes and stronger. So the first 1,000 days of life is from conception to a child's second birthday are considered as one of the most period for. That's why we always think ourselves healthy mothers always give birth healthier children, and healthier children always become productive. This impacts the generations. India offers an excellent example how consistent investment in maternal and child health and what we call as produce an outstanding outcome. One of the example for maternal and child health model is scale. You all know that remarkable outcome. It is possible with limited resources. A state like Kerala, where a lot of emphasis is given on healthcare and education. You all know that Kerala has one of the lowest mortality. You also agree with me, Kerala has an high female literacy and also a significant improvement in the maternal and child health. The reason for significant improvement in maternal and child health model is strong primary healthcare network, which is present in that particular state. Community health workers also played a significant and vital role in health promotion and disease prevention. So institutional deliveries, they have a great impact in what we call it as improvement in the maternal safety. So Kerala's experience always shows that social development and healthcare, they always go hand in hand. The other important aspect what I want to stress is female education is consistently associated with improved child survival, better nutrition, and increased healthcare utilization. You all agree with me that Kerala always reminds us that investing often uses they are only focusing on investing in what we call as infrastructure. While physical health receives considerable attention, mental health also remains one of the neglected areas globally. Now, next recommendation focuses on prioritizing the mental health. You all agree with me that mental health is an essential component of an overall health. Yet it continues to receive insufficient attention and funding from majority of the countries in their budget. Around 1 in 8 people worldwide, they experience what we call as one or the other type of mental health condition, which can be depression, which can be other mania, it can be any other type of like suicidal tendencies, depression and anxiety being the significant contribution for mental illness, leading to disability and so giving emphasis on mental health services should be and one of the important aspect and these mental health services should be always integrated into the primary health. It's very, very important. So that people will have reduced stigma and encourages many people to come and seek timely help for their depression and anxiety and various other mental illnesses. So digital mental health services also can improve accessibility to these what we call it as underserved region. Government should always focus on allocating greater amount of resources and budget. All know that the COVID-19 pandemic increased or it caused a lot of mental health for individuals. Primarily, this pandemic, especially COVID-19, it increased anxiety, depression, and stress across population. As a result of which, what does it indicate? Highlights the need for resilient mental health system in a country. We readily discuss, all of us, you all agree with me, and you all, I think you are with me, what I am telling now, that we always ready to discuss about, like, for example, I will discuss with everybody openly that I am a diabetic, I have hypertension. Okay. Yet many people still hesitate to talk about depression and anxiety. We need to change this particular mindset, which is very, very important. Protecting health also requires what we call it as detecting the threat before this threat becomes magnanimous and start causing what we call it as crisis for day-to-day activity. Now, let us discuss about what we call it as robust disease surveillance system. One of the greatest lessons what we learned from COVID-19 is that early detection always saves lives. You know? So disease surveillance, or always what it will do is it enables early identification of outbreaks. So rapid reporting facilitates timely public health responses. That's why it is always important that we need to integrate digital surveillance. What it will do is it improves the coordination between the agencies. There should be an improvement in the laboratory capacity, which is very much essential for accurate diagnosis. You all agree with me that without laboratory or enhancing the laboratory capacity, it is difficult for us to detect as well as respond. The other important aspect what we need to give our emphasis related to disease surveillance system is data sharing between the country to country there should be a sharing of the data. Data sharing always strengthens the global health security. It always they have a better preparedness whenever there is an or whenever we need what we call it as emergency response in case of any kind of issues or you also agree with me that artificial intelligence nowadays, AI and digital technologies are increasingly supporting the outbreak prediction and real-time disease monitoring. We need to use artificial intelligence and digital technologies for disease surveillance system. Imagine that if COVID-19 taught us anything, is that delayed information can cost thousands of. So that's why detecting disease is only one part of the preparedness. You also ensure that there should be an uninterrupted, what we call it as medical supplies available everywhere is another important component. So the recommendation 5 is called as strengthening the global medical supply. The pandemic, it has exposed serious vulnerabilities in global medical supply. All know that certain countries had a very good supply chain management, whereas other countries they didn't have any kind of supply chain management. And many countries during this COVID-19 experienced what we call as shortage of medicine. Even in India, we had shortage of oxygen, we had a shortage of PPE. So diversifying manufacturing will always reduce the dependence on single suppliers. We always dependent on China. We always dependent on other developed countries with all this supply. So strategic stockpiling of these supplies will always improve during emergency preparedness. That's why we always should focus on giving emphasis on what we call it as regional manufacturing hubs to be strengthened for health security. You also should focus on having a lot of what we call international collaboration. That is from you need to have an international collaboration between country to country. What they will do is it play a very important role in equitable distribution during the crisis, especially in a crisis such as COVID-19 pandemic. What it will do is it play a very important role in maintaining supply chain resilience, and that should become one of the important national health priority. You all should remember that supply chain resilience is now considered as an important component of both healthcare and national security. So the next important point, all of you should remember that because of changing scenario, which is occurring in every day our countries as well as society is threatened with war. You all agree with me that the next global emergency may not be another pandemic. So, but strong supply chains will always remain an essential, regardless of whether we'll have an emergency pandemic or you have any other form of it. So, healthcare should extend far beyond hospital. should begin with conditions in which people are born, where they are growing, where they are working, where they are living. Healthcare should distribute everywhere, not only in the hospital. So my my sixth recommendation is addressing what we call as social determinants. What is this? You all know that medical care alone cannot create an healthy population. Once they come to hospital, freeing them from illnesses and will not create what we call as healthy population. What an individual need is what we call it as a social determinants of health. Is every individual need what we call it as clean drinking water. Know that everybody should have an access for clean drinking water. Clean drinking water will prevent many infectious diseases. Every individual needs safe sanitation. You all agree with me that safe sanitation reduces the child mortality and improves the community health. Every individual should have an accessibility for good nutrition because good nutrition will always support physical growth and cognitive. Everybody should have an access for education because individual who is educated will improve the health literacy and will adapt preventive behavior. Every individual should have a safe housing and clean environment where he is living will always reduces the disease risk. So, as an government, it is our responsibility, people who are sitting in political system or who are running the country, they need to address these determinants and produce what we call it as long-term improvements in population. You all agree with me that research suggests that social determinants, what I said before, influence a large proportion of health outcome. Often, it is more than what medical treatment alone can do. So a prescription cannot replace what we call it as a clean water, adequate nutrition, or and safe housing. That brings out to my next recommendation, which is called as technology. You know, so you all agree with me that digital health has transformed the way the healthcare is delivered nowadays. Everything is digitalized. Nowadays, lot of emphasis is given on telemedicine. Telemedicine, what it has done is it expand the specialist services care to and remote communities. Nowadays, lot of importance is given to digital consultation. Broadband connectivity, nowadays, it has become an essential health infrastructure everywhere. So digital literacy, it is important both for the patient as well as healthcare providers. Nowadays, we have what we call it as mobile health applicators. These applicators, what they do, they support disease monitoring and health education. You have digital watches, we have rings, all that. What this digital technology, what they will do is they complement the human center. Artificial intelligence. Nowadays, you have a lot of variable devices like watches, things and all. And remote monitoring, they expected to play an increasing and important role in future healthcare delivery. So today, to think a specialist consultation can occur across continents within minutes because of the telemedicine. Technology, every day it is changing and healthcare need to adapt this technology quickly. I want to tell you that India provides one of the world's largest, what we call it as a telemedicine system, which has implemented everywhere in India. I want to address that particular aspects now. That is called as India's e-Sanjeevani platform, which usually demonstrates how digital innovation can significantly improve what we call it as healthcare accessibility. So now nowadays, because of this e-Sanjeevani, rural population have improved access to the specialist care. This e-Sanjeevani, what it has done is it has reduced unnecessary travel from community to an metropolitan city. Especially, it had played a very important role in COVID-19 pandemic. Several countries nowadays they are exploring what we call it as similar digital health models, which play a very important role in improving the healthcare access, especially in an area where there is an underserved population. This e-Sanjeevani success will always remind us that innovation is not limited to a geographical boundary. So effective solutions you can also develop and it can be utilized worldwide. You always agree with me that while technology play a very important role in strengthening the healthcare delivery, people always what we call it as I call people always remain the heart of every healthcare system. So next one, what I am going to emphasis on in my next recommendation is called as we call it as global health workplace. This is my recommendation number 8, where you all agree with me that healthcare systems are only strong if you have a very good what we call it as global health workforce or the infrastructure or the professionals who deliver care. Even if your country is having a best infrastructure, that cannot function without what we call it as global health workforce. You all agree with me that nowadays WHO also is there is a shortage of nearly 10 million healthcare workers by 2030. Especially, I'm talking about low and middle income countries. This shortage, when I mean these shortages are primarily, I'm talking about shortages of doctors, nurses, midwives, public health professionals, and allied healthcare workers. So that is why it is always important that modern healthcare education should always incorporate digital learning, usage of artificial intelligence, and interprofessional education is very, very important. Attract what we call as global health. Improve the global health workforce, it is always important that you need to give competitive salaries. There should be an opportunity for career progression. There should be an continuing education and safe working conditions to improve the workforce stability. Otherwise, it becomes very difficult for us to have a skilled global health. As an healthcare professionals, we all understand that patients remember the compassionate caregivers more than what kind of technologies we are used to. That's why I always give an importance or emphasis on skilled workforce. And other important point is skilled workforce alone is not sufficient in healthcare facility. It can it cannot withstand what we call it as changes that is occurring in what we call it as future environmental challenge. That's why my ninth recommendation is that is what we call it as increasing the climate resilience in public health infrastructure. You all agree with me that climate change is no longer a future concern. It is happening now. It is already affecting the nation, it is affecting the communities, and it is also affecting our healthcare system. You all agree with me that climate change contributes to lot of heat-related illnesses. Many of our vector-borne illnesses always are because of climate changes. Many of our respiratory disorders and food insecurities. You all agree extreme weather events increasingly what it does, it damages the hospitals, clinic, and healthcare infrastructure. So it is always important that every district, every state, emergency, every hospital, every district, every state should build what is climate resilient hospitals today, which will reduce what we call it as disaster related healthcare disruptions, which are frequently occurring in various countries. You all agree with me that the WHO has identified climate change as the single most greatest health threat what we will be facing humanity in the 21st century. For a second, to imagine a hospital losing electricity during a cyclone while patient depending on ventilator. So building a climate resilient infrastructure is what it will do is can prevent such tragedies. So achieving these ambitious goals ultimately it depends on one critical factor, which we call it as what we call it as adequate and sustainable financing. So my 10th recommendation is we need to focus on what we call it as reforming the global health financing. You all remember that all my 9 recommendations, none of these recommendations can become reality without what we call it as investment in health, or we call it as sustainable investment in health. All the countries should do health as an investment rather than an expenditure. Many countries they think that health is an many countries, you all agree with me, still spend less than their recommended portion of GDP on healthcare. Many governments they need stronger domestic financing mechanism. They should have a transparent governance so that there will be an efficient utilization of health resources. They should use what we call it as innovative financing, or they should bring about what we call as you have health bonds and international partnership. What they will do is they play in bridging these gaps as well as funding for health. You also agree with me that countries that consistently invest in healthcare generally they experience longer life expectancy. They'll have higher productivity and also these countries will have better economic resilience. So having discussed all these 10 recommendations, now let me talk about what it is international collaboration. Is also another important. So we have examined the challenges and I have posed certain with what it as practical recommendation. You all agree with me that transforming the global health, it always requires what we call as long. Our implementation of recommendation always depends on collaboration, which usually should take place between country to country, or collaboration within the government, collaboration between the healthcare institutions, collaborations with academia, collaborations with industry, civil society. They should bring about policies which are evidence based and people centered. That's very, very important. Should continuously monitor and evaluate accountability or ensure accountability from each and every. You all agree with me that sustainable always dependent on how resilient is your health system. You know that many global health challenges cannot be solved by individual countries alone. No, we always depend on each other. So that's why nowadays healthcare or the healthcare system is not the problem of an individual country. So that's why nowadays international cooperation becomes very much essential. So health security, you agree with me that it is a shared responsibility. One country's preparedness always contribute to the global. So this brings us to the we call it as importance of we call it as strengthening the international partnership. So there should be what we call it as a very good partnership or multilateral collaboration, especially organizations such as WHO, UNICEF, or World Bank, regional health bodies, they play a critical. They should share scientific knowledge, which play a very important role in innovation. International surveillance system always important in improving the fundamental health. That's why these organizations should always give emphasis on what we call it as joint research strength evidence-based decision. Many countries should come together, collaborate, rather than competing with each other, especially during emergency. We know that the COVID-19 pandemic clearly demonstrated that no nation can successfully respond to a global health emergencies in isolation, whether it can be a developed country like or for that matter USA. You all agree with me that viruses cross border without passport, not like individual. So therefore, we ourselves, our response must also extend beyond our boundary. Despite the strong recommendations, what I made, recommendation is very easy. Implementation is always challenging. Now, let us focus on what is overcoming the barriers of implementation. There are multiple barriers are there for effective implementation of the recommendations. Those barriers can be in the form of a bill, financial gap in terms of implementation capacity, because the not have strong system, strong workforce, robust data management. Also, they don't have test community community engagement. As a result of which, what happens? These will become what we call it as barriers for effective implementation of recommendation. So, what are the key takeaways? What we have learned today? You know that equity should guide always every. Another important step is foundation of stronger health system. You should focus on prevention. Prevention is more effective than harming than treatment. Digital health should always improve. Digital health should not widen health equality or equity. Climate resilience is now an essential health. We should also focus on what we call as sustainability and our financing. So these are the changes which I have already spoken. So next, this brings to an calling for an action, especially from the level of government, the level of organizations such as WHO, various national organizations, as well as calls for an individual in order to support community health initiatives, put each and every individual accountable for the activities what he is engaged in. At last, I want to tell you that, sorry, at last I want to tell you that we have now discussed about the challenges, the evidence and recommendation. You all agree that the science is what we need to stop. Every country its income and make meaningful. They should give emphasis to the primary care, should give emphasis to the vaccination, nutrition, a part of emphasis on education, innovation, collaboration, political economy is very, very important for what we call as healthier world. So healthier world is not an impossible dream, it is always achievable goal if we work together. As we move forward, one principle must always remain central to every country's health policy. Is what we call it as equity. So equity should be at the heart of every recommendation. So equity always play a very important role addressing what we call it as global inequalities by implementing the recommendations what I have suggested. And for that technology play a major role acts as one of the important force activity, offline capability, also for digital awareness. Uh, the last one, I want to complete my presentation because it's almost 11 o'clock. I want to tell you that imagine a world where every individual has an access to an health care, regardless of where we live or how much we earn. Uh, So that's why I put this slide, the world we choose to build. This vision is achievable through collaboration and commitment. Strong health system proves resilience during future crisis. Prevention should always remain a priority. Health is not merely the responsibility of a health sector. It requires action across other sectors such as education, environment, finance, technology, and governance. The world we build tomorrow always depends on what kind of decisions we make. Finally, I'd like to conclude by thanking everyone for their attention and commitment to improving the global. As I conclude, I'd like to sincerely thank the conference organizers for providing me with this wonderful opportunity to share my perspective on transforming the global health. Today, we explored the current challenges facing global health and discussed 10 evidence-based recommendations, highlighted two practical examples for you in order to demonstrate the change achievable. Our collective responsibility is to translate knowledge into action. Whether we are clinicians or educators, whether we are researchers, policymakers, or whether we are each of us, we have an important role creating what we call it as stronger, more equitable, more resilient system. Last, I'd like to leave you with a quote by Nelson Mandela. A quote, health cannot be a question of income. It is a fundamental human right. With this, let's continue working together so that quality health is accessible to education. Thank you once again. Thank you, everyone.
Thank you, sir.
Anything? Thank you.
Thank you, sir.
Thank you, Girish sir, for this lovely presentation, and thanks to all the audience to having patience and listening to sir. And those who have those who have not muted themselves, kindly please mute yourself, and we will move on to the next session. And she is a guest speaker of the day, Dr. Sandhya Singh ma'am. She is a principal in a NMCH BSc Nursing College, Patna. She is a renowned and a knowledgeable woman in Bihar. Even she has contributed for many of the papers and for the books and many things for the Bihar government. And she is working under the Bihar government over here. And she, as I can say, she has helped many of the poor people also in Bihar for getting the things and for this our nursing department also. It's over to you, Sandhya ma'am.
Hello,
Yes, ma'am.
my voice is audible.
Yes, ma'am.
Thank you so much for giving me this opportunity and your wonderful explanation about me. So, very good morning to one and all. Firstly, I would like to, before discussing my topic, firstly, I would like to giving gratitude to the GR Foundation for giving me this opportunity. Thank you so much. Today we will discuss, I have been provided a topic, clinical executive alignment and policy making. When we listen this term, clinical executive alignment and policy making, then we can think this is a very vast topic. But in reality, when we read this topic, this is a very simple. So clinical executive alignment and policy making, firstly we have to understand what is clinical executive alignment. It means all healthcare leaders who are working in hospital settings, all healthcare leaders, that means doctor, nurses, paramedics, administrator, all the leaders and workers as well as who are working in the hospital settings, when they work together with the same goal, when all the leaders and workers working together with the same goal to provide a safe, patient-centered care. That is, we can say in simply, a clinical executive alignment. So we can say a clinical executive alignment and policy making in healthcare is a coordinated efforts, means mixing all, as I had told you, coordinated efforts of all healthcare executives, clinical leaders, policy makers to develop, implement, and monitor evidence-based strategies and policies that improve patient care, ensure patient safety, enhance organizational performance, and achieve the healthcare organization mission and strategic goal. If we think a hospital works like a family, in a family, who will be the member? A doctor, nurses, administrator, pharmacist, laboratory staffs, housekeeping staffs. If all members work separately, then that hospital will not grow. But if everyone work together, if everyone work together, patient outcome will improve. So, in clinical executive alignment, we will discuss about the coordinated efforts of all the members who are working in the hospital, who are working for the patient safety, highly skillful care. So today, in my topic, we will discuss about the clinical executive alignment. We will discuss how healthcare policies is making, then what are the relationship between leadership and policies. Then we will discuss about the policy development processes in hospital setting. Then we will understand what are the implementation challenges when we are making a policy for hospital. Then what problems we are facing. Then what are the strategies for successful alignment. These things we will discuss with you in today's session. So as I have discussed about what is clinical alignment? Then clinical executive alignment, as I have told you, who will be the member? Hospital executives, medical leaders, nursing leaders, all the HODs of all the departments, and financial leader, quality managers, and all work together with the common organization goal. I'm giving here the simple example. Suppose, imagine in your mind a boat. If a doctor is rowing a boat in one direction, and if a nurse is also rowing a boat in another direction, administrator is also rowing a boat in another, somewhere else, then whether this boat will reach its destination? No. But if all doctor, nurses, and administrator all are rowing a boat in the same directions, then they will reach the destination very quickly. So, if we make any policy, any things, we will work together. So, in simply, we can say the process of ensuring that clinical leaders and executives share the same vision, priorities, and responsibilities for achieving a same goals. So, this is a clinical executive alignment. Then we will think we are discussing about the clinical executive alignment. Then why this is important? Why we are discussing? Why alignment is important? So is important because we have to improve our patient outcome. We have to improve patient outcome, better financial performance, reducing medical errors, increasing staff engagement, faster decision making, better patient satisfaction, effective resource utilization. If alignment are maintaining in your hospital, then all things will be. If a patient is admitted in our hospital, their care, they receive a highly effective care, quality care, patient-centered care. If we are maintaining alignment, suppose a patient having a breathing difficulty, nurses immediately inform the doctors. Immediately informs the doctor. What doctor will do? Doctor immediately start treatment. The nurses gives the oxygen. Pharmacist arrange emergency medications. Laboratory staff performs urgent investigation. And housekeeping staffs clear the emergency area. Everybody will work together. The patient survive. This is alignment. So we are mainly focusing on alignment. अगर किसी भी हॉस्पिटल में जितने भी मेंबर्स होते हैं, अगर सभी लोग एक साथ मिल करके अगर काम कर रहे होते हैं, तो हमारा क्या होता है? टाइम की भी बचत होती है, कॉस्ट इफेक्टिवनेस होता है, और जो हमारी ट्रीटमेंट जो हमारा है पेशेंट का, जो बहुत एज अर्ली एज पॉसिबल वी आर गिविंग टू द ट्रीटमेंट टू आवर पेशेंट्स. इससे क्या होगा कि जो हमारा complications जो है, if you are giving a treatment to your patient, if you are identify the complication as early as possible, then you can treat the patient immediately. And if a patient is managing in your settings, then you can manage. If your setting is not enough to treat your patient, then you have to stabilize the patient as early as possible, and immediately you have to refer the patient with the SSRH. So though alignment is very important, so we are focusing on alignment. That means कि all the members, doctor, nurses, all सब लोग एक कॉमन गोल्स के लिए काम करते हैं हॉस्पिटल में. हॉस्पिटल वर्क्स आल्सो लाइक अ फैमिली. देन वी कैन proceed, then we can improve, and we can able to give the quality care to the hospital, to the patients, and to our community people. For this, alignment is very important. Then what are the components of clinical executive alignment? So when we are making a clinical executive alignment. We are means discussing about the who will be the members of clinical executive alignment. Then what things we have to focus when we are making clinical executive alignment. In each of the members, doctor, nurses, paramedics, all members, everyone work together. So their vision is also a shared vision. Everybody should know why we are working here, हमारा क्या गोल है और हम क्या काम कर रहे हैं. जब भी हम ये करते हैं, एक्सिक्यूटिव अलाइनमेंट की बातें करते हैं, तो हमारे दिमाग में हमेशा ये चीज होना चाहिए, मीन्स एवरीवन नो अबाउट द प्रोफेशनल साइलोज नहीं होना चाहिए कि दिस वर्क आई एम डूइंग, आई एम परफेक्ट, दैट्स व्हाई आई एम डूइंग दिस, बट you are giving care, you are a role model, you are providing care to your patients. तो at that time एक ही बंदा कभी भी अकेला कुछ नहीं कर सकता है जब तक कि टीम वर्क नहीं होती है. तो टीम वर्क होने के लिए जो आपका विजन है वो एकदम क्या होना चाहिए, शेयर्ड विजन. एवरीवन हैज अ क्लियर विजन, व्हाई वी आर हियर and what care we have to provide to our patients. So shared vision is very important. Then effective leadership. जो जब टीम वर्क की अपन बात करते हैं, when we are talking about the team work, then effective leadership is a very important. Leadership style should be a transformational leadership. जितने भी आपके सबऑर्डिनेट है, जो भी मेंबर्स हैं, वो मोटिवेट उनको करना है, और उनको जो भी अगर उनकी गलतियां भी है तो आपको उनको ट्रांसफॉर्म करना है, और गोल्स के बारे में उन्हें आपको बताना है कि हमारा गोल है और हाउ टू अचीव दैट गोल, दैट थिंग्स यू हैव टू फोकस. देन collaboration is very important. If you are doing anything, if our interprofessional teamwork, if we are not maintaining IPR, then we will not success in anything we are doing. We are giving care to our patients. Hospital is meant for providing quality care. So at that time, accountability is very important. Clear role and responsibility. We are making a SOP, a standard operating procedure in the hospitals. All the roles and responsibilities are written. So all the members, all the staffs of the hospital, they should know what role they have to play in their setting. And accountability is very important. They have to accountable for their work. Performance monitoring is very important when you are providing services to your patient. So evaluation is very important. Continuous quality improvement. If you are not evaluating what types of care you are giving to your patients, then how can you improve? So continuous quality improvement is very important. Always evaluation, continuous evaluation is going on. When we are making a executive alignment, members, all the things, components we have discussed, what things we have to do for making these alignments. So some barriers we are facing. What types of barrier we are facing for making these alignments? First one thing, प्रोफेशनल साइलोज, जिसके बारे में अभी हमने डिस्कशन करा कि प्रोफेशनल जैसे बहुत सेटिंग्स में हम लोग भी देखते हैं, व्हेन वी आर वर्किंग इन द हॉस्पिटल सेटिंग्स, सम फेलो आर वेरी स्मार्ट, वेरी टैलेंटेड, वेरी क्वालिटेबल, बट सम आर नॉट. बट एट दैट थिंग्स, इफ अ स्मार्ट वन, जो लोग टैलेंटेड है, जो हाईली स्किल्ड है, वो अगर जो कम स्किलफुल है, अगर वो उनको नहीं सिखाते हैं, नहीं उसको एक्सप्लेन करते हैं, तो फिर क्या होता है कि अगर हम कॉमन गोल की जब बात कर रहे होते हैं हॉस्पिटल सेटिंग्स का, तो दैट आर नॉट फुलफिल्ड. तो दैट थिंग्स वी हैव टू फोकस. ये चीजें जब टीम वर्क की बातें करें तो उसमें प्रोफेशनल साइलोज नहीं होना चाहिए. सो हम लोग वी आर वर्किंग for a common goal. तो जो भी हमारा विजन है दैट शुड बी अ क्लियर. बट अगर प्रोफेशनल साइलोज है तो वी आर ट्राइंग to remove that things. Then communication gap, it is a very important. So many times we saw in the hospitals communication gap. Suppose patient हॉस्पिटल में एडमिट है और सपोज कीजिए पेशेंट का ब्लड प्रेशर फॉल कर रहा है और आपने डॉक्टर्स को नहीं बताया. अब इसमें क्या होगा, आप लेट करा आपने बताने में, तो जब बताने में ही आपने लेट करा तो क्या होगा, पेशेंट का ट्रीटमेंट ही लेट होगा, तो फिर आपका आउटकम क्या होगा, गलत होगा. तो इसीलिए कभी भी कम्युनिकेशन गैप नहीं करना है. जो भी चीजें एज अर्ली एज यू हैव टू कम्युनिकेट टू द सीनियर्स. एंड मिसकम्युनिकेशन भी नहीं होना है कि जो भी आप कम्युनिकेट करते हो अपने सीनियर्स को, तो योर लैंग्वेज शुड बी क्लियर एंड ऑलवेज रीस्टेट द प्रॉब्लम. एंड ऑलवेज रीस्टेट इफ अ डॉक्टर is saying sister, or if a senior is doing, you have to do these things, then at that time you have to restate, sir, you are saying these things. That means it should be more clear because you are working on the humans. आप जो काम कर रहे होते हैं ह्यूमंस के ऊपर काम कर रहे होते हैं, तो आपको क्या करना है कि आपको restate always when you are communicating to the doctors, to the seniors, always restate the problems. अगर आप इसको ऐसे करते हैं तो क्या होता है कि ट्रीटमेंट स्टार्ट्स वेरी क्विकली, द लाइफ ऑफ द पेशेंट इज सेव्ड. सो गुड कम्युनिकेशन ऑलवेज प्रिवेंट द कॉम्प्लिकेशंस. सो ऑलवेज focused on the communication gap. So these are the this is a very important barriers in the alignment. Then resistance to change. Resistance is a very common thing, so we are seeing in the hospitals. खास करके जब अपन जो पुराने जो सीनियर्स हो जा बंदे रहते हैं, कुछ कुछ हैं, तो जो उनकी जो सपोज कीजिए कि हॉस्पिटल्स में अभी इंफॉर्मेशन टेक्नोलॉजी के द्वारा आया हुआ है कि सारा डाटाबेस जो हमारा है उसको हमें कंप्यूटराइज कर देना है. बट कुछ लोग ऐसे होते हैं कि उन्हें लगता है नहीं, जिस सिस्टम पे हम काम कर रहे हैं, जो हमारा पेपरलेस हमें वर्क नहीं करना है, वी आर डूइंग मैनुअली. तो एट दैट टाइम्स अलाइनमेंट में जो हमारा ये भी एक बहुत ही इंपॉर्टेंट मीन्स बैरियर्स होता है. तो इसको भी हम लोग को क्या करना है कि इसको भी हम लोग को ट्रेनिंग दे करके स्टाफ्स को उन्हें मोटिवेट करके आपको इसको दूर करना है, इस बैरियर्स को. देन कॉन्फ्लिक्टिंग प्रायोरिटीज. कॉन्फ्लिक्ट भी ग्रुप में बहुत सारी आती रहती हैं. देन लैक ऑफ ट्रस्ट, फिनेंशियल कॉन्स्टेंट. बहुत सारे समय में हम लोग को देखने को मिलता है कि फिनेंशियल भी बर्डन्स रहती है कि नहीं ये हम नहीं कर सकते हैं. सो दीज आर ऑल द बैरियर्स to alignment. Then inadequate leadership skill. If you are a leader and you are not competent enough to lead your goal, to lead your team, then how can you achieve the goals? So firstly, when you are a leader, you should be a competent for leading your group. Then poor organizational culture. If an organization have a poor organizational culture, कोई टाइमिंग नहीं है, कोई क्वालिटी वहां मेंटेन नहीं हो रही है, पेशेंट्स है, डॉक्टर वो अपना काम कर रहे हैं, सिस्टर अपना कर रही हैं, फार्मासिस्ट जैसे मैंने भी आपको एग्जांपल दिया. इफ ऑल मेंबर्स आर रोइंग अ बोट इन अनदर डायरेक्शन इन समवेयर एल्स, देन हाउ कैन यू रीच योर डेस्टिनेशन? सो ऑलवेज ट्राई to work together, then we can reach our goal, then we can achieve our goal. So these are some barriers to clinical executive. जब भी अपन हम कुछ करते हैं, ऐसा प्लान बनाते हैं, तो ये सब हमारा क्या है, बैरियर्स हमारा आता है. और इसी में क्या है, चैलेंजेस. ये भी एक बहुत ही इंपॉर्टेंट है कि जब हम ऐसा प्लान करते हैं कि हमें एक साथ मिलकर वर्क करना है और अपना हॉस्पिटल की प्रोडक्टिविटी, क्वालिटी जो हमारा उसकी एफिशिएंसी, इफेक्टिविटी में बहुत हायर लेकर जाना है, तो क्या क्या चैलेंजेस वी आर फेसिंग. तो फर्स्ट वन इज राइजिंग पेशेंट एक्सपेक्टेशन. आज के डेट में क्या है, पहले नाउअड मीन से पहले और अभी के चेंजेस में, नाउअडेज ऑल द पेशेंट्स एंड पेशेंट रिलेटिव्स आर मोर क्वालिफाइड। एंड अभी जो हम लोग देखते हैं सोशल मीडिया, जो हमारे गूगल बाबा हैं, ऑल द नॉलेज आर शेयर्ड इन द गूगल। पेशेंट आर कम मीन्स कमिंग इन योर सेटिंग्स। एंड जो भी आप उनको ट्रीटमेंट बता रहे हो, जो केयर बता रहे हो, वो क्या करते हैं कि पहले ही उन्होंने चैट जीपीटी, गूगल पे सारा ट्रीटमेंट पढ़ा हुआ है। तो उनका एक्सपेक्टेशन जो होता है वो आपसे बहुत ही ज्यादा बड़ा होता है। तो उस एक्सपेक्टेशन को आपको फुलफिल करने के लिए भी एक बहुत ही इंपॉर्टेंट चैलेंज है अभी हेल्थ केयर प्रोफेशनल्स के पास में। देन इंक्रीजिंग हेल्थ केयर कॉस्ट। जो भी हमारा हेल्थ केयर कॉस्ट, जो मीन्स जो भी आप ट्रीटमेंट करवाने जा रहा हो, अल्ट्रासाउंड है, एमआरआई है, पेट स्कैन, जो भी आप करवा रहे हो, उसका कॉस्ट बहुत ज्यादा है। स्टाफ शॉर्टेज इन मीन्स गवर्नमेंट सेटिंग हो या प्राइवेट सेटिंग, ऑलवेज वी आर फेसिंग दिस प्रॉब्लम्स वेरी मच। One and two staff nurses are working in a 60 bedded, 100 bedded hospitals in a ward. Only 2 or 4 nurses. How would it be possible? Then we will think that they are providing a quality care. So these are the some challenges we are facing, and we have to, इससे हम लोग को बाहर निकलना है। देन क्वालिटी इंप्रूवमेंट। हमने ऑलवेज वी हैव टू फोकस ऑन द क्वालिटी। कि जब भी हम कोई भी अगर हॉस्पिटल्स में हम कोई पॉलिसी बना रहे हैं, कोई टीम बना रहे हैं कुछ गोल के लिए, तो ऑलवेज वी हैव टू फोकस ऑन द क्वालिटी। इफ योर क्वालिटी इज नॉट गुड, देन नो वन इज कमिंग in your hospital. And why they have to pay enough, and you are not providing quality care to to the patients and her relatives. So it also a very big challenge to us. Then digital transformation, regulatory compliance, effective executive alignment is very essential to address. So always we have to focus effective executive alignment. तो how should it be done? कैसे हम लोग इसको कर पाएंगे? तो इसके लिए क्या होता है कि वी हैव टू टेक अ रेगुलर meetings, regular monitoring. If we are monitoring regularly, then we are knowing the challenges, knowing the जो भी हमारा जो कमियां है और how to improve. So regular meeting is very important in the hospital setting with all the executive, जो भी हमारा क्लिनिकल एग्जीक्यूटिव है, जिसके बारे में अभी मैं पहले आप लोगों से डिस्कशन कर चुकी हूँ कि हु आर द मेंबर्स इन द क्लिनिकल एग्जीक्यूटिव अलाइनमेंट। तो ऑल द मेंबर्स शुड मीट शुड मीट कम से कम 15 दिन में एक बार जरूर उन लोगों को एक बार मीट मिलना है। और उस पे एक हमेशा क्वालिटी के ऊपर में आपको क्वालिटी सर्कल बनानी है और उस पे आपको काम करना है। देन वी कैन अचीव आवर गोल। तो हाउ वी कैन improve our alignment? So these are some techniques by which we can improve the अलाइनमेंट प्रोसेस। शेयर्ड गवर्नेंस, जो भी आपका, जैसे कि हमने बताया पहले ही आप इस पे हम लोगों ने डिसीजन मीन से डिस्कशन किया हुआ है। शेयर्ड विजन, जो मीन्स डिसेंट्रलाइज करना होगा आपको वर्क को। ऑलवेज जो भी आपका वर्किंग है उसको क्या होता है कि डिसेंट्रलाइज कीजिए और उसको रेगुलरली यू हैव टू फोकस, यू हैव टू मॉनिटर। देन लीडरशिप डेवलपमेंट करना होगा, ज्वाइंट डिसीजन मेकिंग करनी होगी। देन क्लिनिकल गवर्नेंस, डिजिटल डैशबोर्ड बनाना होगा, रेगुलर एग्जीक्यूटिव मीटिंग्स, transparent communication, performance incentives. These are the very important things. If your team members are doing a very nice job, so we have to उनको क्या करें, reinforce them. Then we have to कि उनको कुछ भी आप incentive, if you are giving incentive is not means for the monetary only. और ऐसा नहीं होता है कि ओनली आपको कुछ पैसे ही इंसेंटिव्स के रूप में अगर आप दे रहे हो। आप अगर कभी उन्हें कुछ प्रशस्ति पत्र जी होता है, कुछ लेटर के द्वारा ही आप उसको मीन्स अनाउंस करवाओ उनका नाम, या सबके ग्रुप में ही मीटिंग में ही अगर आप उनको अप्रेज कर रहे हो, तो दे आर फीलिंग मच मोर बेटर rather than the monetary. So these things we have to always keep in our mind कि we have to do these types. Then we can improve our alignment process. Then we will discuss about the clinical leadership structure, कि how in the hospital leadership are formed. Firstly, in any settings, first जो हमारा है हॉस्पिटल की जो बोर्ड कमिटी है वो बोर्ड कमिटी होती है. Then we are making a CEO, chief executive officer, then chief medical officer, CMO, then chief nursing officer, CNO, chief operating officer, COO, then chief financial officer, CFO, then all the heads of the departments and हेल्थ केयर प्रोफेशनल जो भी है, ये सबको मिला करके ऑल जितने भी मेंबर्स हैं सबको मिला करके ही हम लोग क्या करते हैं, एक क्लिनिकल एग्जीक्यूटिव बोर्ड बनाते हैं. और उसके अनुसार फिर हम लोग अपना जो भी हमारा हॉस्पिटल का जो पॉलिसीज है उसके अकॉर्डिंग हम लोग वर्क करते हैं फॉर मेंटेनिंग, फॉर अचीविंग आवर गोल्स, फॉर प्रोवाइडिंग अ क्वालिटी पेशेंट सेंटर्ड एविडेंस बेस्ड केयर देने के लिए. तो ये सब जो मीन्स अभी हमने डिस्कशन करा क्लिनिकल एग्जीक्यूटिव अलाइनमेंट्स, तो ये सब जो अभी तक हमने बताया कि क्या होता है, इसमें कौन बंदे होते हैं, हाउ वी आर मेकिंग, व्हाट आर द कंपोनेंट्स, ऑल दैट थिंग्स. तो ये सब करेंगे. तो ये सब करने के लिए क्या होता है कि आपको सबसे पहले यू हैव टू नो द पॉलिसी मेकिंग, यू हैव टू अंडरस्टैंड द पॉलिसी. व्हाट इज पॉलिसी? देन सिंपली वी कैन से कि पॉलिसी क्या होता है, कि पॉलिसी सिंपल लैंग्वेज वी कैन से रिटन रूल्स एंड रेगुलेशन. It is simply a SOP, standard operating procedure, कि how these procedures will work, how to do. So these are written rules and guidelines. So it is a systematic process of developing, implementing, monitoring, and revising healthcare policies to improve quality care, to improve evidence-based care for the patients. तो ये हमें क्या होता है कि पॉलिसी. तो अब हम लोग बात करेंगे कि क्यों ये पॉलिसी, तो ठीक है ये रूल्स रेगुलेशन हमने बनाया, तो क्या व्हाट शुड इट बी डन, व्हाट शुड बी डन, हु शुड डू इट, कौन इसको करेगा, व्हेन इट शुड बी डन एंड हाउ इट शुड बी डन. कोई प्रोसीजर है, कोई पॉलिसी आपने बनाया, तो इस पॉलिसी को कब इम्प्लीमेंट करना है, इस प्रोसीजर को कब इम्प्लीमेंट करना है, कौन इसको करेगा, कैसे करेगा. दैट मीन्स ऑल शुड बी क्लियर टू ईच एंड एवरी मेंबर्स ऑफ द हॉस्पिटल. Those who are providing the care, that fellow should know their roles clearly. After that, they will able to perform their role very efficiently. सपोज करो कि जैसे सभी हॉस्पिटल्स में हैंड हाइजीन पॉलिसी है ना. Everyone's know hand hygiene is very important before doing any procedure to our patients. Every healthcare worker must clean hands before touching a patient, after touching a patient, before procedure, after removing gloves. Everyone follow the same rules. अगर सभी लोग इस सेम रूल्स को अगर फॉलो करते हैं तो आपका जो आउटकम होगा, जो आपका इन्फेक्शन का जो रोल रेट होगा वो क्या होगा, कम होगा. और आपने ये पॉलिसी बना दी है कि दीज आर द पॉलिसी व्हेन वी हैव टू डू, कब हमें करना है और किस किस बंदे को ये करना है. तो इससे क्या होता है कि एवरीबॉडी विल फॉलो दीज थिंग्स. इसके लिए ही हमें पॉलिसी बहुत इंपॉर्टेंट होती है. ठीक है. अगर हम पॉलिसी नहीं बनाते हैं, सपोज कीजिए हमारा हॉस्पिटल्स है, वी आर नॉट मेकिंग एनी पॉलिसी, और हॉस्पिटल्स गवर्नमेंट का भी है या जो भी प्राइवेट सेक्टर के हॉस्पिटल है, इफ दे आर नॉट मेकिंग एनी पॉलिसी, तो उस कंडीशन में क्या होगा, एवरीबॉडी विल वर्क डिफरेंटली. someone will perform hand washing, someone will not. और अगर डिफरेंटली काम करेंगे तो क्या होगा, this causes confusion, very confusion. So policy is very important. Policy ensures, if you are making a policy, policy ensures क्या करता है, patient safety, equal treatment, each and every individual, each and every patient who are coming to your hospital, they are acquiring same care, equal treatment, quality care, legal protection भी होगा, then standard practice. So these are the importance of policy when we are making policy. So why we are making? For preventing of these things. Why healthcare policy matters? अभी हमने आपको अच्छे से हम लोगों ने वी हैव डिस्कस्ड अबाउट दैट थिंग कि पॉलिसी इंश्योर्स पेशेंट सेफ्टी, लीगल कंप्लायंस, इथिकल प्रैक्टिसेस, स्टैंडर्डाइज्ड केयर, efficient use of resources, and accountability, quality improvement. Here I want to give one example. Suppose the medication means I'm talking about the medication administration policy. Everybody will know about the 7 hours of drug administration. Suppose कीजिए the nurse follows the right patient, right drug, right dose, right route, and a right time before administering the medicine to the patient. So this reduces क्या होगा अगर आप if you are following 7 hours to the before giving the medicines to your patients, तो क्या होगा कि आपका जो मेडिकेशन एरर है दिस विल रिड्यूस, ये क्या होगा कम होगा. तो इसी में हम लोग क्या करते हैं कि जब सारा कुछ करने के लिए हियर यू हैव टू means make a policy. How you are making a policy? First thing, you anything means किसी भी चीज पे आपको पॉलिसी बनाना है तो सबसे पहले व्हाट वी आर डूइंग, वी आर आइडेंटिफाइंग द प्रॉब्लम. फर्स्टली you have to identify what are the problems are occurring in these settings. Then suppose many patients, means I am giving an example, many patients are getting hospital acquired infections. Many patients are getting hospital acquired infections. तो क्या करना होगा, तो आपको स्टेप 2 में क्या, why this occur, तो all the information, all the data you have to collect. Then when you are collecting the data, then why infection are increasing. जब डाटा आपको मिल जाएगा और डाटा मिला और उसी में आपको भी डाटा कलेक्शन के दौरान ही आपको कॉज पे भी जाना है कि क्यों ऐसा हो रहा है, क्यों इन्फेक्शन रेट बढ़ रही है, व्हाई इन्फेक्शंस आर इंक्रीजिंग. देन यू हैव टू प्रिपेयर द पॉलिसी. इंट्रोड्यूस. देन जब पॉलिसी बनाएंगे तो उसमें ही आपको क्या करना है, इंट्रोड्यूस इन्फेक्शन मीन्स आपको क्या इंट्रोड्यूस करना पड़ेगा, आपको इन्फेक्शन प्रिवेंशन पॉलिसी. आपको वहां पे लाना होगा स्ट्रिक्ट हैंड हाइजीन. जो अगर हैंड हाइजीन if we are following before touching, before giving, after doing procedure, तो these things we have to make. तो आपने पॉलिसी बनाया, then after that we have to train the staff. जितने भी आपके स्टाफ हैं वो सबको क्या करना होगा, we have to giving the training to your all the staffs member. ट्रेन करना होगा, सभी को आपको ट्रेन करेंगे. टीच ऑल हेल्थ केयर वर्कर्स. देन व्हेन you are making the policy, training आपने दे दिया सबको, you have given the training. After that you have to implement the policy on everybody should follow this policy. अगर इस पॉलिसी को सभी लोग फॉलो करते हैं then उसके बाद फिर आपको क्या करना है, मॉनिटर रिजल्ट. फिर उसके बाद आपको इवैल्यूएट करना है, उसके बाद रिजल्ट को आपको क्या करना है, मॉनिटर करना है. एंड चेक इन्फेक्शन रेट्स एवरी मंथ. इफ इन्फेक्शन डिक्रीजेज, अगर इन्फेक्शन डिक्रीजेज हो रहा है देन योर पॉलिसी इज सक्सेसफुल. इफ infection is not decreases, then you have to make another policy. So these are the some process by which we can make a policy. Types of what are the type means how many types of healthcare policies we have to make. First one is the clinical policies. Like जैसा कि अभी हमने बताया आपको, मेडिकेशन एडमिनिस्ट्रेशन का पॉलिसीज बना सकती हैं, इन्फेक्शन सभी कुछ का, each and everything we are performing in the hospital, all things have a policies. Then administrative policy, how many human resources about the doctor, nurses, paramedics, housekeeping staffs, security, सभी का आपका होना चाहिए कि उसका भी आपका एक एडमिनिस्ट्रेटिव पॉलिसीज रहेगा एचआर के ऊपर में। देन फिनेंशियल पॉलिसी होगी, बजट, कुछ भी चीज कोई भी हम अपन जब स्टार्ट करते हैं तो फर्स्ट थिंग आपके पास में क्या बजट होना चाहिए, बजट एलोकेशन किस किस डिपार्टमेंट में किस चीज में हमें कितना बजट एलोकेट करना है। तो फॉर दैट वी हैव टू मेक अ financial policies. Then infection control policies, it is a very important, we have discussed about thing infection control policy. Then patient safety policy, it is a very important thing. कोई भी पेशेंट सेफ्टी पॉलिसीज बनाना है, कोई अनकॉन्शियस पेशेंट है, कोई वायलेंट पेशेंट है, तो हाउ टू कीप दैट पेशेंट्स, हाउ टू केयर द पेशेंट्स, ये सब चीजें क्या करना है कि आपको ये सब की पॉलिसीज बनाना है। सभी का एसओपी बनता है, स्टैंडर्ड ऑपरेटिंग प्रोसीजर, एंड दैट एसओपी शुड बी मेड ऑलवेज by the means if you are a clinical person, you are doing in clinical settings, then you have to make the policies for the clinicals, not for the administrative policies is made by the administrator जो जिस चीज के स्पेशलाइज्ड है, that fellow are making policy of that things. So these are the some healthcare policies we are making. In policy making cycles, we have discussed already how we have a maker. Then first thing means you have to identify the problem, then evidence collect, stakeholder consultation, then draft policies. After that approval होते हैं, then उसके बाद you have to implement, then monitoring. After monitoring whether your policy is good, effective or not. If a policy is your effective, then policy is good. And another, अगर ये नहीं effective हुआ, then you have to make another policy. So these are the steps for the policy making. In a stakeholders in policy making, who will? So firstly, government organization will make a policy. In a hospital management also play a means also बनाते हैं वो हॉस्पिटल ये आपका पॉलिसीज। देन डॉक्टर, नर्सेस, पेशेंट्स, ये सभी को और प्रोफेशनल काउंसिल्स, insurance agencies, accreditation bodies, and public health experts, all are the stakeholders for this policy making. When we are making a policy, then always keep in mind that all policy when we are making that should be a evidence based. क्योंकि जो भी हम पॉलिसी बनाते हैं, इफ एविडेंस बेस्ड नहीं होता है, एविडेंस बेस्ड, देन वो पॉलिसी आपका सक्सेसफुल नहीं है। इसीलिए ऑलवेज हम लोग को कोई भी अगर हम लोग रिसर्च जो भी हम पॉलिसी बनाए तो उसके लिए चीज फोकस करना है कि हमारा पॉलिसी जो है वो किसी रिसर्च पे बेस्ड होना चाहिए। तो कैसा, किस पे? क्लिनिकल रिसर्च, कोई अगर उस पे रिसर्च हुआ क्लिनिकल्स पे, या WHO ने रिकमेंड किया है उस, अगर जैसे हम लोग हैंड हाइजीन्स की बात करते हैं कि वी हैव टू डू हैंड हाइजीन इफ यू आर मेकिंग अ हैंड हाइजीन पॉलिसी, तो उस पे कितना रिसर्च हो चुका है, तो वी हैव टू रीड बिफोर मेकिंग दिस कि जो रिसर्च हुआ है वो जो हमने स्टेप्स बनाया है हैंड हाइजीन का, वेदर दे आर इफेक्टिव और नॉट। तो ऑल थिंग्स वी हैव टू keep in mind always before making a policy. So what are the sources? Like clinical research, WHO recommendation, national guidelines, hospital audits, patient feedback, quality indicators, incident reports. All these things we have to keep in the mind when we are performing when we are making a policy. Always think about this. Clinical governance and policy. Clinical governance includes when we are making a policy, at that time also we have to focus about the risk management. What are the risks when we are performing, when we are doing care to our patients, to what risk we will face. So before making these things, we have to keep in our mind. Then clinical audit, evidence-based practice, continuing education. Continuing education is very important. If you are trained as staff in one time and you are not monitoring that things, तो वो क्या होगा, फिर वो आपका फेल हो जाता है. तो ऑलवेज आपको क्या करना है कि ऑलवेज हमेशा एक रेगुलर इंटरवल्स पे आपको कंटिन्यू हमेशा एकदम मॉनिटरिंग करते जाना है और कंटिन्यू आपको एजुकेट करते जाना है, ट्रेनिंग देते जानी है कि वो कभी उसमें लैक नहीं आए. अगर जैसे लैकिंग होगा, फिर आपका क्वालिटी केयर जो है, जो आपका जो जिसके लिए आपने पॉलिसी बनाई है, क्लिनिकल एजुकेटिव अलाइनमेंट एक टीम बना हुआ है, वो कहीं ना कहीं आपका जाकर के वो फेल हो जाता है. इसीलिए कंटिन्यू एजुकेशन एंड कंटिन्यू मॉनिटरिंग इज वेरी इंपॉर्टेंट फॉर सक्सेशन ऑफ योर गोल. Patient safety, quality improvement. So all these things are very helpful for enhancing, for supporting the policy implementation. Role role of nursing leader. What types of roles nursing leaders should perform in policy making? It is a very important. We नर्सिंग लीडर कंट्रीब्यूट बाय पॉलिसी डेवलपमेंट. कैसे करेंगे वो? स्टाफ एजुकेशन, क्वालिटी मॉनिटरिंग, इन्फेक्शन कंट्रोल, पेशेंट एडवोकेसी, ऑल दीज आर वेरी इंपॉर्टेंट. और ये सब जो है सेक्शन, ये सारा हम नर्सेस के द्वारा ही मेनली फॉलो किया जाता है. पेशेंट एडवोकेसी, चेंज मैनेजमेंट, क्लिनिकल सुपरविजन, दीज आर वेरी इंपॉर्टेंट. तो क्या क्या कर सकते हैं? जैसे ऑलवेज हम लोग, जैसे सपोज इन हॉस्पिटल, हैंड वॉशिंग इज वेरी इंपॉर्टेंट. मेंटेन पेशेंट प्राइवेसी, ये बहुत ही इंपॉर्टेंट होता है. और सपोज कीजिए कोई मिस्टेक्स हो गया, तो ये सब चीज को रिपोर्ट करना, ये सारा चीज किसके द्वारा होगा? नर्सिंग फेलो के द्वारा ही. और रिस्पेक्ट एवरी हेल्थ केयर वर्कर्स, जितने भी वर्कर्स हैं सबको हम लोग रिस्पेक्ट करते हैं. कुछ अगर परेशानी आ रही है, कुछ भी कॉम्प्लिकेशन आ रहा है, तो तुरंत में हम लोग क्या करते हैं? कम्युनिकेट करना है. तो ये सब जो रोल्स है, ये सब नर्सिंग लीडर के द्वारा ही होता है. तो उनका क्या रोल होगा? सपोज कीजिए पॉलिसी बनाने में, अभी मैं यहाँ पर एक एग्जांपल आप लोगों को देना चाहती हूँ. हियर आई हूँ. सपोज कीजिए कि रोल ऑफ नर्स क्या होगा पॉलिसी मेकिंग में, तो मैं उसके बारे में, सपोज कीजिए कि स्टूडेंट है, कोई स्टूडेंट नर्स notices that an IV line has become loose. Suppose मतलब she is working in hospital, when she is going for their clinical exposure, at that time she felt कि उसका जो clinical जो IV line है, that are मतलब वो लूज हो गया है. तो इंस्टीड ऑफ इग्नोरिंग, क्या होता है, बहुत भी हम लोग भी देखते हैं कि ठीक है वो डैमेज हो गया है, लूज भी है, तो बहुत सारे बंदे क्या करते हैं, एट दैट टाइम दे इग्नोर्ड इट. कोई नहीं, दूसरा कोई देखेगा. बट क्वालिटी में इसकी कोई जगह नहीं होती है. तो इंस्टीड ऑफ इग्नोरिंग इट, सी immediately what will she do? She immediately inform her clinical instructor. अगर इमीडिएटली क्लिनिकल इंस्ट्रक्टर को अगर वो इन्फॉर्म करती है, तो क्या होगा? द प्रॉब्लम इज करेक्टेड इमीडिएटली. तुरंत में क्या होगा? ये प्रॉब्लम इमीडिएटली हो जाएगा. और पेशेंट जो होगा आपका, उसका पेशेंट की सेफ्टी जो होगी वो इम्प्रूव हो जाए, इम्प्रूव करेगी. तो ये सब चीजों को हमेशा ध्यान रखना है कि आप जो नर्सिंग में जो पॉलिसी का क्या इम्पोर्टेंट है. तो पॉलिसी जब हम लोग बनाते हैं, तो एट दैट टाइम all these things we have to means keep in our mind. Always quality monitoring, infection control, patient को advocacy करना. You have to you have to work as a change management. Then clinical supervision. क्वालिटी की जब हम लोग बातें करते हैं कि केयर में, मीन्स नर्सिंग के परपेक्ष में, नर्सिंग पर्सपेक्टिव में क्वालिटी का, तो फर्स्टली व्हाट थिंग वी हैव टू थिंक, व्हाट वेंट रॉन्ग, क्या गलत हुआ, हाउ कैन वी इम्प्रूव, कैसे हम लोग इसको इम्प्रूव कर सकते हैं, देन वी मेक चेंजेस। पहले अगर जैसे अपने से क्या गलत हुआ और हाउ कैन वी इम्प्रूव, तो फिर जैसे हम लोग इस पे थिंक करते हैं, देन उसी समय हम लोग को उसको ठीक करने का उपाय हमारे पास में आता है। तो सपोज कीजिए कि फॉल्स आर, मान लीजिए किसी वार्ड में क्या हो रहा है कि फॉल्स जो पेशेंट है वो गिर गिर जा रहे हैं, फॉल्स का रेट जो है बहुत इंक्रीज कर रहा है। तुरंत में अगर मीन से जब फिर वी आर मेकिंग अ पॉलिसी, उसमें हमने डाल दिया है कि अगर इस टाइप के पेशेंट है तो बेड रेल्स आर रेज्ड, जो बेड का जो रेल्स है वो हमेशा क्या होना चाहिए, रेज करके रखना है। पेशेंट रिसीव असिस्टेंस व्हाइल वॉकिंग, जो पेशेंट्स इंडिपेंडेंटली वॉक नहीं कर सकते हैं तो उनको क्या करना है, असिस्टेंस देना है। ये सब चीज अगर हमारा पॉलिसीज में ही अगर है और एवरीवन विल रीड दैट पॉलिसी, एवरीवन नो दैट थिंग्स व्हाट वी हैव टू डू इन दिस सिचुएशंस, तो क्या होगा, पेशेंट रिसीव, पेशेंट का जो क्या होगा, पेशेंट रिसीव दिस टाइप्स ऑफ केयर एंड फॉल रेट आर डिक्रीजेस। तो ये सब चीजें हैं जो हम लोग को nursing leaders, as a nursing leader we have to think before making the policy। एंड क्वालिटी इंप्रूवमेंट फ्रेमवर्क, क्वालिटी इंप्रूवमेंट फ्रेमवर्क में हम लोग हमेशा बातें करते हैं पीडीसीए का, या पीडीएसए बोले या पीडीसीए। तो व्हाट इज पीडीसीए, पीडीसीए इज अ प्लान डू चेक एक्ट या प्लान डू स्टडी एक्ट। इसको भी हम लोग करते हैं मीन्स कि कोई भी अगर प्रॉब्लम होता है, तो जब प्रॉब्लम आपको पता हो रहा है कि दीज आर द प्रॉब्लम्स, देन वी हैव टू मेक अ प्लान। आपको प्लान बनाना है कि हाउ टू इम्प्रूव दैट प्लान, then we have to implement your policy, your guideline। जब आपने इम्प्लीमेंट करा उसके बाद आपको स्टडी करना है, आपको चेक करना है कि वेदर आवर मींस प्लानिंग इज सक्सेसफुल और नॉट। अगर वो प्लानिंग आपकी सक्सेसफुल हो जाती है, देन दैट शुड बी अ इम्प्लीमेंट्स, उसको एक्ट बना देना है, उसको करना है। दीज आर द प्रोसेसेस बाय व्हिच वी मेकिंग अ पॉलिसीज। Here we are showing one case study. Suppose this is a problems. Medication error increased by 18% in the hospitals. What we do? Executive committee formed. तुरंत में क्या होगा, कमेटी बना दिया, न्यू मेडिकेशन पॉलिसी वहां पे इंट्रोड्यूस किया, स्टाफ को ट्रेनिंग हमने दे दिया, देन बार कोड मेडिकेशन सिस्टम इम्प्लीमेंट किया। तुरंत किसी की मेडिसिन ही बार कोड वहां लगाया, रिजल्ट आया मेडिकेशन एरर रिड्यूस्ड बाय 45%, पेशेंट सेफ्टी इंप्रूव हो गया। तो by which we can make a policy. So these things we have to keep in our mind. Then challenges इन पॉलिसी इम्प्लीमेंटेशन, जैसा कि अभी हम लोगों ने क्लिनिकल एग्जीक्यूटिव में भी पढ़ा था, सेम टाइप्स ऑफ प्रॉब्लम वी आर आल्सो फेसिंग इन द इम्प्लीमेंटिंग द पॉलिसीज। स्टाफ रेसिस्टेंस, समवन डोंट वांट टू चेंज, उन्हें चेंज नहीं होना होता है, जैसा है बस उनको उसी में रहना है। तो फिर हम लोग को क्या करना है, उसमें आपको उनको ट्रेनिंग देनी होगी, उन्हें मोटिवेट करना होगा। दीज टाइप्स ऑफ थिंग्स वी हैव टू रेगुलरली, continuous monitoring, continuous training is very important। then limited budget, ये भी एक हमारा बहुत मीन्स बड़ा चैलेंज होता है। पुअर कम्युनिकेशन, पॉलिसी इम्प्लीमेंटेशन में कम्युनिकेशन जो है वो बहुत इंपॉर्टेंट होता है, कि इफ यू आर नॉट शेयरिंग प्रॉपरली बिटवीन योर डिपार्टमेंट्स हेड, योर सीनियर्स, तो क्या होगा, मिस अंडरस्टैंडिंग हो जाती है, और इससे क्या होगा, पेशेंट केयर सफर करेगा आपका। इसीलिए ऑलवेज आपका जो कम्युनिकेशन जो होना चाहिए, गुड कम्युनिकेशन। लैक ऑफ ट्रेनिंग, इफ यू आर प्रोवाइडिंग लैक ऑफ ट्रेनिंग टू योर स्टाफ्स, तो वो ट्रेंड ही नहीं होंगे, तो हाउ कैन दे इम्प्लीमेंट द प्रोसीजर। देन पॉलिटिकल इन्फ्लुएंस, ये भी बहुत देखने को मिलता है कि सब पॉलिटिकल प्रेशर अगर आपके ऊपर आ जाता है, उस समय भी हमारा पॉलिसी अच्छे से इम्प्लीमेंट नहीं हो पाता। फ्रिक्वेंट पॉलिसी चेंजेस, अभी आपने ये पॉलिसी बनाया, बस तुरंत में नया पॉलिसी बना दिया। तो दीज आर द सम challenges we are facing in implementation of the policy। So what things we have to recommend for policy implementation and clinical executive alignment के लिए क्या क्या हम लोग को करना चाहिए? फर्स्ट थिंग वी हैव टू बिल्ड अ कोलाबोरेटिव लीडरशिप। Collaborative leadership we have to develop. Then encourage always evidence based decision. कोई भी ऐसा डिसीजन नहीं होना चाहिए जो कि एविडेंस बेस्ड नहीं होना है. अभी के समय में nowadays we are practicing evidence based practice. Evidence based midwifery practices, evidence based care, all things we are performing that have a proof. If someone is asked from you how this policy, why this policy means has made, then you have to show these are the evidence by which we are making these things. Then strengthen clinical governance, engage frontline staff जो रूट केयर वर्कर हैं, वो भी उन सबको आपको इन्वॉल्व करना होगा. When you are making a policy, then that policy will successful. Invest in leadership training and promote patient-centered care. Always keep in mind that when we are providing care, when we are making a policy, तो always हमेशा हाई में हमें किसको रखना है, पेशेंट को. पेशेंट सेंटर्ड केयर ही हमें always keep in our minds. Then what are the key points we have discussed in today's session? First, we have discussed about the clinical executive alignment. So for clinical executive alignment, how we are making clinical executive alignment? Leadership plus collaboration plus accountability. These things always keep in mind. In leadership, that means all the members of the hospitals, all the leaders, workers should work jointly, should work together for common goal, for providing highly qualitative, patient-centered care. These things we have always keep in mind. Then when we are making a policy, before making a policy, always we have to focus on the evidence. Who after that you have to plan, then implement, and after implementation, always evaluate. Continuous monitoring is very important for successful or your policy. So before closing my session, some points I want to say before you people. Always remember these points. Patient is always the center of healthcare. Always patient ही गॉड है हमारा, और ऑलवेज पेशेंट को ही आपको सेंटर में रखना है. देन उसको पाने के लिए क्या करना होगा, टीम वर्क इज स्ट्रॉन्गर देन इंडिविजुअल वर्क. ये कभी नहीं सोचना है कि आई विल एनफ और मैं इसको अकेला कर सकता हूँ. ऑलवेज प्रमोट teamwork. Teamwork is always stronger. Policies create a safe and standard care. Always make a policy. Then communication prevent errors. Always communicate. If a simple कभी भी थोड़ी सी भी confusion आती है तो always communicate with the seniors. Every nurse is a leader in patient safety. Each and every nurse, as a future nurse and healthcare leaders, always remember one team, one goal, one patient. Always remember one team, one goal, one patient, safe and quality care for all. Thank you so much to all for your patient listening. Thank you from my side.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
If anyone wants to ask any questions, please welcome.
All the participants, if they want to ask any questions to Dr. Sandhya Singh ma'am, they can ask the questions if they are having any doubt. As I can see in the chat also earlier, someone has asked a question to ma'am, explain about the something question, or if anyone is having any query, then they can ask. Thank you, ma'am. As it seems
Thank you
that no
so
one is
much.
having any doubt.
Yeah, thank you so much to all. Thank you.
Thank you, ma'am.
So now we are moving to our next speaker for the today, Dr. Vasantha Kumari Sundarajan ma'am, who is an assistant professor in nursing from College of Nursing, College of Applied Medical Sciences, King Faisal University, Al Haza, Kingdom of Saudi Arabia. A very welcome to you, ma'am, in the international conference. Hope, ma'am, I'm audible to you.
Yes, yes. Hope I'm audible to you all. Good
Yes,
afternoon to
ma'am.
everyone.
Yes, ma'am.
Good afternoon, ma'am. Good afternoon, ma'am.
Okay, shall I continue?
Yes, ma'am, you can continue the session.
Okay, thank you. Thank you so much. Thank you so much for the welcome note. And thank you so much for the kind opportunity. I think I have requested for the sharing of slides. Can you please do it?
Just 1 minute, ma'am.
Okay, thank you. I'll just say next. So if I say next, then I think you will be able to move on. Is it okay?
Yes,
Can you
ma'am.
hear me, please? Yes, okay, thank you. So let me start without delaying. So welcome to the international conference organized by the very esteemed the GR Academic Foundation and a very beautiful team and very good team, the need of the hour, global health inequalities and nursing strategies. Because we nurses are the heart of the healthcare and we have more key role and also we are the key professional in this. So I think it's a very important topic where we need to bridge the gap. So coming to the next slide. So already my introduction has been given. I'm Dr. Vasantha Kumari from okay, and my topic is going to be on sustainable development goals and health equity. So when the topic was given to me, I was thinking, okay, nothing because SDGs is already there from 2015. We are going on with the SDGs all the time, and health equity actually because of I think WHO, well, the World Health Organization, health equity is very famous term. So which is already known to all of us. So I was thinking, okay, no problem. What I'm going to take like that, I was thinking. But once I started to prepare the content, because my focus was on the current aspect, because I don't want to beat the bush, because already people have known something. Like if I'm going to talk on the same thing, it won't be perfect also. So I was just thinking, but when I gone into that, I found a lot of things we need to know as nurses, because where we are lacking, because many times nowadays we are going with research, because now I'm in abroad and I know how much important research is being given country when we were here, because the problem is with the publications, the money. But here in other countries, they have a fund and we have to go with the funds and we can do it. But here also, in our country also, we have that. But many times we don't know. We are unaware of the amenities and facilities, or also the whatever feasibilities are there. We have not opportunities. We don't know, because opportunities will not. Actually, they say opportunities will knock at the door, but it will not knock at the door. We need to go and search for the opportunities, and surely we'll be able to get and we'll excel. So that is where the problem is. So here I'm going to talk about the SDG and health equity for the nurses, which is going to be in a broader aspect. Okay, next slide, please. Next slide. Okay, so coming to the introduction, let me talk about the previous slide, previous one. Okay, thank you. So being a nurse, next one, next. Okay. So being a nurse, I think everybody knows. It means that we need to be aware of social injustices, and also we need to go with the systemic racism. We know very well it is existing in nursing also nowadays, and also having a personal and professional responsibility mainly to tackle the challenges and also help to end them. So we know in globality, in the global issues, global views, global perspectives, we don't enter into that. We are nurses, nursing professionals. We do our work, come back, and we are taking care of our family, and we are going with the work-life balance or work-family balance. That's it. we never think, but we have a lot of responsibilities as a citizen, as a healthcare professional, being the heart of healthcare professional. We have a lot of responsibilities because we are around us. We can see a lot of injustices happening and lot of problems like racism, classism, everything is happening, but we are not able to voice out. We are not able to come out only, but we need to be very much thankful to many leaders nowadays, and especially all our associations, also other leaders, those who are very much assertive, and they are really coming out very well. And nowadays, I think the politics has come into our profession too. People are coming, all are just trying to go with politics, because I could see many of the status of my colleagues, our nursing professionals. I'm seeing them taking the photos with the ministers or with the political people, and I'm being very happy. It's actually it's a proud moment because we have to involve, then only we'll be a part of the change. So being a change agent, it is not only being in the healthcare sector or being in the industry or being the university and just trying to give the education or just trying to give the healthcare. We have to be a part in achieving the SDG goals, the 17 goals. It's not only a few goals that is targeting the nursing profession. We are also part of other goals too. Okay, next one. Next slide. Next slide. Can you go to next slide? Okay. So coming to the SDG, the Sustainable Development Goals, mostly we know this agenda, it is actually a universal one. So it is actually, it has been signed by in 2015 by United Nations. The member states, 193 member states have gone into the signatures, and the targets are 169 targets. So here mainly they are going for a universal call, and where they are trying to develop. So we know the pillars of our nation, of our global pillars. If you see, it is humanity, human being, and also the social change, economic change, also the environment. So here we are going with the target, the societal and environmental, economical, we are targeting. So when you talk about the SDGs, it was adopted by the 193 UN member states in 2015, and main vision is we are trying to achieve it by 2030. That is the target. So that target, the involvement of the countries are 169 members are there in the target, and we need to be very proud because top 100, our India is there. Because last year, 2025, our position was in 99th position, but now we are in 94th position. Within a year, we have just gone up, and we are in top 10, with top 100, which is really a proud moment. We need to be very much thankful to the government and our Indian government and all the states and all our member citizens for the contribution, because mainly the target was on the hunger, the poverty. The poverty is reduced. The other amenities like electricity, it is all, and infrastructure and all that is being given for the people, and people are able to go with the living, the peaceful living. But only thing, what still know where we are not coming up, where we are lacking is mainly in the gender inequality is still there. Still we are not able to come. We are not able to go with the that one. The equality is not there. So the gender inequality, also the zero hunger, because there are malnutrition issues, hunger issues are still, it is existing. So here, this SDG is very important because it's going to give a roadmap for the government, business people, for the civil society, because we need to align with the policies and we have to go with the investments mainly for achieving the measurable outcomes. So it is not only the responsibility of the government to achieve this 2030 agenda, it is also the responsibility of each and every citizen, and more in that the contribution, the majority of contribution will be for the healthcare professionals, where we are in a majority, nurses. Okay, next one. Am I audible? My voice is audible to the audience?
Yes, ma'am. Yes, ma'am.
Am I audible?
Audible, ma'am.
Okay. So next, kindly go to that. Okay. So here when we see, it's a blueprint, mainly for the peace and prosperity. We'll be seeing it. I'm not going to go on with many things. So we can see, so the main game is mainly it has to address the global challenge. It's a global health. So global, not only global health, the full globality. So the global challenges has to be addressed, where we need to balance the economic, social, and environmental sustainability, where the main principle is leave no one behind. No one should be left behind. That is where we are talking about the equity. So equity is where we should not leave anybody behind. Everybody should be given All should come. So because equality and equity is having a different term. Okay, next one. So here it talks about the many 5 P's. So poverty, peace, planet, and prosperity, which is very important. Next one. So it should be done in a sustainable way. So what we have to do? We have to go in a sustainable way, and we are trying to achieve this. So here, the health equity, when we talk about health equity, all know very well, it is actually a fair opportunity, mainly for the health across population, because as the term says health. So here we have to give them, we need to see that we have to address the barriers and the disparities, and it should be a equity. So the policy should be coordinated, all the community people should engage, and it should be data driven accountability. Without the data, without any scientific data, without any evidences, we cannot. So there should be accountability. So that's where equity. So here, when you talk about the equity, mostly we have to say that it should be a fair and justifiable one, and it should not affect. It should not be something, it should not like non-remediable or non-available something. So it should not be that. So in this picture, I think everybody can see the picture. You can see 2 things. You can see that equality and equity. In equality, we can see we are going to give them the equality resources. The resources will be given equally. All the 3 chairs, we have seen all the 3 chairs are given equally to everybody. But in that, one person is tall and one person is short. But you can see the disparity. But in equity, what is happening? You're going to target the specific needs. So a person is tall, you're giving a chair. A person is short, you're going to give another chair. So that the person is going to get 2 chairs, and that is making the person to come stand along with the another person. So here in equity, we are trying to give the resources based on the specific needs. Okay, next one. Next slide. So when we talk about the SDG and health equity, you know, SDG is having 17 goals. So I'm not going to list down that because it's already, I think you can see that. You can see the goals. So this 17 goals, whatever we know already, now we are going to focus on nursing. So this 17 core goals, which is going to start with the poverty, hunger, health, education, equality, clean water and sanitation, affordable and clean energy. Next one. Next slide. Next slide. Next, please. So next one is actually a decent work and economic growth, industry, innovation, infrastructure, and also we are talking about many things. The climate action will be there, life below the water, that is the marine resources, life on the land, animals, and also the other habitats. And we are talking about the peace, justice, strong institution, partnerships. So here, actually, they say we have to be a responsible citizen, even in choosing the proper leader, so that we'll be able to achieve the target. Next one. Next slide. Next slide, please. Okay, so when we talk about this, now I think you can see this. This is the one, 2030. The framework is we are going to go with the global sustainable development. So here we need to fulfill the global health. Previous slide. We have to fulfill the global health. Also, we have to see that we are going with the economic development. We have to go with the climatic development. There we are going to have an agenda. We are going to have a timeline. So what is the timeline? I think the speaker he has spoken about the universal health coverage. So universal health coverage, there are many things which we have to go into that. Like we have a lot of schemes. And here the timeline, what is being given, we can track. We have to go with the national plans, voluntary reviews, and periodic United Nations assessments has been done in this case. So that's what I have already told our position, 94th position we are there. So that is because of the tracking we are able to identify. But still, we are having a doubt whether we'll be able to achieve this because we are nearing. Now we are in 2026. 2030 is very much nearing. Only 4 years is remaining, and within 4 years, we don't know whether we'll be able. That is 2030 December, we need to achieve this particular development, that is the sustainable development should be achieved. Next one. So when we are talking about the goals, SDG goals, we have to see that all the 17 goals is going to represent its own views. So here we have a lot of overview and targets. And when we talk about the overview and targets, we can see the universal call is already been given, action is already taken, and lot of transformations are there, because we can see lot of changes. So we have to see that we all should focus on our needs, mainly to transform the lifestyles, to promote the equality, to go with the human rights, and to go with the justice. So here also we have to see that we are meeting the needs of the current generation, but we have to keep in mind the future generation, because today what we are doing, deforestation, and also we are trying to do a desertification. We are trying to take the land degradation, biodiversity issues are there, habitats, so many animals are becoming extinct, so many marine resources are lost, so many land resources are lost. Oxygen is less because carbon dioxide emission is more because of the manipulation and misuse. But we are not thinking about the future generation, because our own kids, our own children, our own generation are going to come. They are going to stay. They are going to take over our position. That time they should not suffer. So we have to see that this current need should be met, but you have to focus on the future generation too. Next one. Next slide. So here, when we talk about that, so the focus, already I told, the focus should be on people, planet, prosperity, peace, and partnership. So these are the very important 5 P's which we need to target. Next one. Next slide, please. Next one. Okay. So the origin and purpose, why we have started, because we all know very well the Millennium Development Goals, 2000 they started, and 2015 was the end period, and 8 goals was given. And this one, they wanted to continue also the global development efforts, because we know very well globality. We are not talking about the country. We are not talking about the region, because nowadays all the countries one. The war is happening in one place, but still all the countries are affected. So the conflict, the problems, the climate change, whatever is going to happen in other place, it surely so it is all interlinked. It is all interconnected. So the global development efforts is very, very important. So all the countries, countries has to unite together. Then only these problems all can be completely averted, and we'll be able to achieve the goals. So this is mainly helping. It is going to help the global development. It is going to help the nation. It is going to help the earth on the whole. So here we have to see that the action can be promoted by economic dimensions, social dimensions, environmental dimensions, where we are going to go with the inclusive partnerships. So we can take the partnerships. It can be private, public partnership. We can take the, even healthcare professionals can go with the other discipline partnerships. So we can go with partnerships, other countries, member country partnerships. So we can do this and we can try to integrate the action. Okay, next one. Next one, please. Next slide. So this is how it has come. So the MDG started. Okay, so now we can see these are the 7 goals. So where we have to see that the poverty should be in all its forms everywhere, not only in one place, everywhere. Same time, the end hunger. So where we have to achieve the food security, nutrition should be improved, sustainable agriculture should be promoted. Also, when we talk about the healthy lives should be promoted, well-being, especially we have to see that the physical, not only physical health, mental health, that is very, very important nowadays. So at all ages, they should be promoted. Same time, the inclusive and equitable quality education, because without the quality education, people cannot proceed. So quality education and lifelong learning opportunities. So here I want to say something. I was working in... Hello? Okay. When I was working in Ethiopia for 7 years, we had a colleague. The colleague was from engineering department. He is also from India. So now presently he was working in North India. From there he has gone to North India. He was working in North India, and again I saw his name from the LinkedIn somewhere. He has gone to Delhi. He was heading an incubation cell hub, and again now I'm seeing him study. He was an engineering person with a lot of experience from the government, and he had a lot of publications. When he was there in Ethiopia, we could see that his publications were at the top level. But yesterday, when I was seeing his publications, I found 2% Stanford scientist. He's coming under that. And it is really a great honor. And I saw him now. He left the job and he's in Bixpilani doing artificial intelligence and machine learning. See how the people are trying to progress. We should not. So there's no end. Lifelong learning opportunities are very important. As per the technology, we need to try to update ourselves, update our skills. So also gender equality is very important, and women and girls should be empowered. Where the vulnerable population, all the time the discrimination should not be given, but then only the gender equality will be promoted. Also the availability and sustainable management of water and sanitation. That's very important. Same time, energy. So sustainable energy and modern energy is important for everybody. That should be given. So that everybody should have access for that also. Next one. So where we are trying to promote the equity. Next one. Next slide, please. So next one is actually when we talk about other goals, we can see that. So there will be other things like we are going to talk about the other sources where we are trying to see that the inclusive and sustainable economic growth should be promoted, employment opportunity, and also decent work. Everybody should go with the decent work. What is decent and indecent work? We all know very well. It is nothing indecent. Every work is work. All should take up the work based on the particular qualifications, and based on their own skills, people will be given the employability opportunities and need to take up the skills. So the work, whatever they take up, it is all a decent work and they need to go with it. Also, there should be a resilient infrastructure. It's very important. Without infrastructure, nothing can be done. Also, industrialization is improving, sustainable, and also the innovations. So everywhere we can see the incubation and innovations are nowadays, it's a priority. Also, inequality should reduce within the countries and among the countries. Also, cities should be a settlements, like it should be a proper UN settlements. It should be safe, it should be resilient, and it should be sustainable. Similarly, the pattern, sustainable and consumption pattern and production pattern is very, very, very important, because here only we are talking about the generations. We see a lot of problems because many times we waste the resources. So we are wasting many things. Electricity we waste the water. So sometimes we don't get water, but sometimes we don't. How many people are having the habit of putting off the tap? We don't do the turning of the tap. They don't do that. Most of the time the water will go waste. The resources will go waste. Wasting the food, all the wastage. So that we reuse, revitalize. Again, we try to reproduce. Many things are there, but still most of the time we are trying to waste only. Also, urgent action should be taken, especially for climate change, because every country and all the countries have signed the treaty, and in the treaty they are mainly telling that the climate change, especially this climatic condition should not exceed more than 2%. But still now we see what is happening even in the European countries. We know very well many problems have started because of the climate. I think historically people, even that, I think this is the first time in the history, I think people are finding the climate too hot. It is too hot in the European countries, and we are getting the informations. And we saw somewhere, I saw the social media also, the tires are becoming melted. Many things are happening. It's too hot. So this is because in India, as Indians, we know very well, we are used to this climate. So it's not a surprise for us. But sometimes in some countries, this is something new because they have not seen this type of climate. So the change is already started. Similarly, the conservation of the ocean, conservation of the seas, marine resources, how much we are conserving. That is very important. Next one. Because we are not keeping anything clean. We are trying to contaminate the water. We are trying to contaminate plastic pollution. It has become a big problem nowadays. It's because of us. It's a human error. Next one. Next slide. Next slide. So here, when we talk about the last aspect, we have to protect, restore, and promote the sustainable use of the terrestrial ecosystem, that's the land. Also, we should try to see that the development should happen in the society, peaceful development. People should live their life peacefully and with prosperity. Also, strengthening the implementation process and also the partnerships for sustainable development is very, very important. Next one. Next slide. Next slide. Next slide, please. Okay, so in nursing, now we are focused on nursing SDG. So very importantly, holistic nursing. When we talk about holistic care, we have to focus on the social determinants, because social determinants of health, it is a very important core pillar, because housing, property, environment, nutrition, neighborhood, all the amenities, all the facilities are coming under this. So that's all comes under the 17 SDGs. Also, when we talk about the global continue.
Yes, ma'am.
Okay, now voice is audible.
Yes, ma'am.
Yes,
The voice
ma'am.
is audible.
Yes, ma'am.
Okay. I don't have any problem. My internet is good only. I don't know what is the problem. Okay. So global scope, if you see, mostly we can see the nurses. They are making the largest segment of population. And most of the time we can see they are the majority of the healthcare force. So it is very, very important for the nurses, because they need to execute the initiatives and they have to go with the targets. So most of the time we are not doing it. I told you, because we don't have the time also. Same time, the fear, and we are not very assertive. That's the biggest problem with nurses. Still, we are not coming to the forefront. We are the forefront workers. We are very talented. We are very much expert. We are more knowledgeable. We are more skillful. Most of the time, we never try to reveal ourselves. We never try to come in the front. So mostly that is where we are lacking. So whenever you see the politics, many times, where I think very rarely nowadays we can see nurses are coming, but still very, 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 very less. This era, I think we have to take over. Majority of the nursing force should be into politics, because that will be very helpful in trying to, because the government, when we enter into the policy, we are going to become policy makers. We are going to be the what to say, we are the key professionals. We know very well. We can give our inputs very nicely compared to others. So all this will be very important for the nation or the global development too. Next one. Next slide, please. Next slide. Okay. So when we talk about the SDG 3, see, here I'm not talking about other SDGs. In SDGs, whatever we are going to talk, we need to talk about the SDG, where nowadays we can even go with the poverty, no hunger, also coming as a nurse's role. Also, when we talk about that one, the climate action, the inequality, gender inequality, so health inequality. So all these nurses also are playing very important role. But the focus on SDG3 is very important. We are playing a very major role. Good health and well-being. It is our complete role has been there in this SDG3 achievement. So here we are trying to see lives, promote well-being. All the agencies are being done by us, where we are going with all the preventive, promotive, and curative aspect and rehabilitative aspect. So we are trying to reduce the mortality rates, and we are trying to go with the vaccination program. We are trying to prevent the neonatal and death, because they're all very important. Because we are going to try, we are very much checking the vital statistics, and just trying to reduce the mortality and morbidity rates. Also combating the communicable diseases, very important diseases, and also treating a non-communicable diseases, which is very important nowadays, and also the mental health issues. That is a common one. Also nowadays, even the social issues, communication issues are also there, because of the other gadgets, people are not communicating with each other. And also universal access, mainly to the sexual and reproductive health care, is also very important, and universal health coverage. So these are the things which need to be concentrated by the nurses. Okay, next one. Next slide. So when we talk about SDG 3, I think we have to mainly focus on certain things, like where the nurse will be the drivers. So what are the drivers? Drivers means we are trying to drive the scenario. We are the one, we are trying to focus on this particular SDG 3. So we are trying to go with the patient care. The patient care is a direct patient care. Also, we have to go with the education and prevention. then the policy making. So I was already talking about the policy and advocacy, advocating. I think that is also many nurses. I don't say all the nurses, but as we are the majority, but still our workforce, although still our contributions are very less comparatively, but still there are many leaders who are very inspirational for us, who are involving the policy making, who are already playing advocacy role. And but when we all join together, I think this what we are targeting now, it will become very easy for the attainment. Next one. Next slide. Next one. So when we talk about the SDG, how it is going to get connected, how it is going to go with the connection with the health. So previously, when I was seeing the old slides. When I was seeing the old slides, I was just checking. It was mainly targeting on the SDGs, which is like 4, 5, 6, and it was targeting mainly on the 13th because it's a climate change. But now we are talking about the hunger, poverty, where we are involving the nurses apart from the SDG 3, also the SDG 1, SDG 2. Also, we are going with the equality, gender inequality, also the climatic change. So in this, nurses' roles are very importantly, it has been taken into consideration. Next one. So apart from the SDG 3, so the 17 goals. So we are not going into the 17 goals. So, but we have to. All the 17 goals, we are having the contribution. We need to contribute, and that is where it is going to help in managing the challenges. Because by 2030, we need to achieve the agenda. To achieve the agenda, we need to go with the challenges. So here we can see the health for workforce strategies are more. Still now, the patient-nurse ratio is less. Also, because there is a need for the investment, more investment in nursing and midwifery education, it's required. There is also many problems like climate. Because of climate, there are a lot of health emergencies and many pandemics are there. And also coming to the inequalities, continuously there are health inequalities and socio-economic barriers, especially for the marginalized and rural communities, tier 2 population. In talking about the tier 2 population, rural area, also the marginalized people like women who are socially deprived, socio-economically deprived people, there is a lot of discriminations we can see. And gender discriminations also can be seen sometimes. So these vulnerable populations, tribal people, sometimes the caste, low caste. So these many things are also happening. So we need to see that all should be treated with the equity. So that is our goal. Okay, next one. So these challenges should be taken into consideration. Apart from that, okay. So where the nurses, so the challenges are the very important focus for the nurses where we need to go with this. So we have many actions. I'll just spell the actions in the later aspect. So the way forward for nurses, very importantly, capacity building. We need to go with the capacity building role, and there is a lot of advanced practice role and primary care role, leadership positions. That's what I already told. Nurses should involve in policy making. We need to involve ourselves in the politics, the government initiatives. We need to be a part of the programs. So that is very important. Also, interdisciplinary collaboration. So where we can collaborate with the other public health officials, community leaders, and also global health organizations. Now, today we are keeping an international conference. I could see some names I'm seeing. It is not from India. Because international people are also inside. So I'm really happy with this because this is where we are trying to share the platform and also share our ideas and thoughts, and we are trying to exchange ourselves. So these kind of collaborations are also very essential for the global development. Next one. Next slide. So here we have certain key aspects, we call it as a key global targets. So what are the key global targets? Already I told, poverty, food security is very, very important, and climate change. These are the 3 things which we are trying to go with, and we are trying to have a lot of progress. We are trying to check the progress, and there are a lot of indicators and also a lot of policy priorities mainly to target on this. Next one. Next slide. So people and planet. So what is people and planet? In people and planet, when we are talking, we need to see that I think that picture, what we have seen, the people and planet, very beautiful area, the beautiful environment, no pollution. We can see a lot of animals and birds and surrounding the people, Where is it nowadays? Are we like this now? Where we are going? No one is going to park. No children are going to play all the time. We go home. We go for work, we come back, we are tired, we are sitting and taking the mobile, and we are sitting in each and one direction, and we are just targeting our mobile, and we are just into that. No one is sitting and communicating with each other. No one is trying to take the good breath from the nature. No one is allowing the nature to flourish, because that's what is happening. We can see that. Okay, next one. Next. But nothing, we are not late. We are not at all late. We can do that. But still we are not doing. Okay, next slide. This is the previous one. Next slide. Anything is required? Somebody is giving a message. Anything is needed? Can I continue?
Yes, ma'am, you can continue, ma'am.
Okay. Okay. So coming to the health and education, because that's also another focus. So I think today from today's SDG, I think you will be knowing we are focusing on SDG 3, but still we are also a part of SDG 1, 2, poverty and hunger, where we are also responsible, and climate change. So when we talk about that, we are mainly targeting our health education is mainly on most of the time the quality services, where we are trying to strengthen that. We are trying to go with the preventive care. We are trying to give them the self-care teaching we are giving. But where nowadays we have to go with many things, which is going to be a lifelong one. So lifelong learning pathway should be emphasized. Preventive care should be emphasized. Workforce capacity should be strengthened. Also, we have to see that the funding should be given. So that is very, very important. Okay. So here we have to go with the universal access for the quality health services and inclusive education. Next one. So climate and biodiversity. In climate and biodiversity, we know very well, the integrated actions are very important, because it has to reduce the emissions. Also, it has to protect the ecosystems. So we need to know very well that the nature-based solutions are more important than resilient planning. Most of the time we lose that resilience. Even ourselves, emotional resilience, we don't have. So whenever we have this, we need to see that this with the resilient planning only we can do that. So also we have to go with the conservation, restoring the habitats, and also we need to see that the climate policy should be framed and it should be aligned. So here we have to see that the ecosystem services should be long-termly, it has to be secured, and we have to go with the climate resilience. So this is where we can try to remove the climatic issues, and we have to go with that like biodiversity issues can be removed, which has become a very big problem nowadays. So we all are suffering because of that. I think all are suffering. Somewhere too much of rain, somewhere too much of hot climate. Because I'm a person now, I'm in vacation, I'm in Chennai, very well, too much, it's burning for us. It's too much burning, and this is the first time, because so many climate, but still this time we could see there is a lot of difference. There is a very much lot of difference in the climate. So this is actually something called as the El Nano. All this people are talking. They're thinking. They're saying that the water is completely. It is becoming getting reduced, and totally there will be scarcity, and totally it will become, the climate will become very hot. And I was just sitting and thinking, now itself we are like this, and in future what is going to happen? Too much of usages of the amenities like ACs and the fan, this electric currents, again it is going to increase when it is going to increase the issues, and it is not going to decrease the issues. So for all this we need to go with the nature-based solutions. Nature-based, too much of trees and too much of natural environment only can save us. Okay, next one. Next slide. Next slide, please. Okay, economy and growth. So we all know without economy, nothing is happening. As nursing professionals, everybody know we all are depending on the money. Without the money, we have to be very proud. Once upon a time, when we all were doing our nursing, when people used to ask us, why did you join nursing? We used to tell, we joined nursing because we need to provide service to the people. But actually, we are there too. We are a passionate people. We have a lot of compassion, dedication. And as a nurses, after joining nursing, we are getting all the qualities and we are going. But why we are joining nursing? Because we know it is like a professional job where we will not be unemployed. we need money. So everybody goes, same time, same thing happens, because without economy and growth, the country also cannot progress. So we need to go with this. And coming to the sustainable industries, we know very well there is a lot of practices. So the carbon production is very, very important. It should be reduced. Also the supply chains, mostly we need to decouple the growth. So the growth should be decoupled, especially by reducing the environmental harm. So the harm should be completely reduced, and green technologies should be promoted, where we need to see that the sectoral transformation and the competitiveness has to be improved, and that is where the standards has to increase, and we can go with the sustainable industries, where we have to go with the greeneries, green technology. Okay, next one. Next slide. Next slide, please. Okay, the decent work, already I told. So what is decent work? Safe work, productive work, and secure job. So that's what we call as a decent work. And again, when we talk about the another thing, what we are going to talk is we are going to talk about the innovation and infrastructure. So that's okay, the decent work, already I told. So we are mainly talking about the good wages, because that's what we are fighting now, nurses, where we are not getting the that are many places, because there still we don't have a uniform wages. Still we are lacking in that. Private and public, there is a difference. And same time, even the private itself, there are a lot of differences. There are a lot of differences from state to state. In the state, so institution to institution. So these kind of things is happening. So this is commonly I'm talking. Coming to the innovation and infrastructure, we are very much important, as we need to be resilient, and low emission infrastructure is very important. So emissions should be reduced. Also, there should be digital connectivity. So that's why I think India is very much ahead of this. So in the particular targets, what we have done, so the digitalization, India is coming to the top level. So also R&D, research and development, still we need to, as nurses, still we are not into this, because all other professions are coming into R&Ds, but still we are not going into that. And public-private partnerships are very, very important, where the corporate and government has to involve. Same time, there should be smart investments and smart solutions, smart technology should improve. Next one, innovations and infrastructures. So we need to talk about the sustainable technologies and how we are going to promote them. Next. So you can see the word everywhere. I'm telling sustainable environment, sustainable technology, sustainable climate. So the everything. So this is what we call as a sustainable growth. So sustainably, we need to, in a sustainable way, we have to improve it. So coming to the implementation and monitoring, everything. So whatever. So now 2030, what we are going to achieve, we need to, there is a monitoring system. So the monitoring system is there. There are many tools are available, and these tools are helping to find out. There is a WHO assessment tools that is helping to track the or it is helping to do the survey and find the report, and just trying to know that target, how much it's going to get achieved. So the implementation monitoring should be at all the levels. Next one. So without that, it cannot, without implementation monitoring, we cannot know whether we are achieving it or not. Next, coming to the policy integration. So everywhere we have to align with the policies, the targets, go with the cross-sector coordination. Also, there should be a regulatory coherence and stakeholder. Everywhere we need to involve the stakeholder. We are not engaging the stakeholder. Even, you know very well, I let me tell you all, I don't know about you all, but because I'm actually starting with my 50s. So when we are a little bit older people. So what happened when I went to other country, I started to hear this word when we started to present our researchers, then the stakeholder. Then only I came to know stakeholder is very, very important for everything. So we have to engage them. If you engage the stakeholder, you will get a lot of inputs. We'll also know whether we are going in the right track, and we will be getting a lot of guidance. Also, sustainability criteria is very important, because we need to put the budget. We should know what to procure, because there should not be any wastages. So we should know whether the policy is effective, and it is also, we need to know the accountability. We need to be very much accountable with whatever we are seeking and using it. Next one. Next. The next slide, please. Okay, financing mechanism. In financing mechanism, already the finance is very important. It has to be mobilized, and the budgets, public budget, private investments, everything should come, and that only the gap can be, the missed gap can be completely filled. So the funding gaps So that is very important. Also, because a lot of the gaps are there, because government cannot completely, we cannot rely on the government. So the government has to go with some kind of fundraising or some kind of funds. Okay, coming to the data and indicators, we need to strengthen the system. So when we are going to strengthen the system, we need to have a proper data. We have to have evidences. With the data driven evidences only, we'll be able to do the assessment and planning and also implementation. So coming to the next part, there is health equity. I will finish fast, don't worry. So these are SDGs. So whenever we are going with SDGs, we need to know what is health equity, because health equity is the one which is helping us to completely go with a fair and justifiable opportunity is being achieved. So to achieve a proper level of health, the fair and just opportunity is only by the health equity. And here we see that everyone is going to attain the full health potential without any disadvantage. All are going to be given the same treatment, justifiable one. Okay, next one. But many where we find a lot of disparities still now we feel, because the government, how we are treated, government hospitals, in the private hospitals, we feel there may be some kind of difference, because a lot of problems, shortage of staffs, shortage of the resources, everything is there. But in private, we don't have that, but still lot of expenditure. We are spending too much of GDP, has been 1.3 to 1.4% of GDP. We are spending out of pocket expenditure for the health only in private sector. Complete wastage. Next one. Next slide. Next slide. Okay. So coming to the foundations of equity, we know the scope. There should be very important scope. So where the populations, we have to target, we have to know the conditions, we need to know the stages, and we need to have a proper goals, and we have to align with the stakeholders and policy frameworks. Then only the health equity can be achieved. Next one. Next slide. So here we are going to, when you go with the health equity, the normal people, the vulnerable people, disabled people, all have to come together. Even the people with the sexual orientation, lot of issues, LGBTQ, we know very well. So all that will come together. So all will go with this and obstacles. So whenever we see the health equity, we have to see that proper treatment should be given where the obstacles are removed. So that's like poverty, discrimination, racism, classism, and also proper jobs should be given, quality education should be given, safe housing, all that should be targeted. The 17 goals, whatever we are talking. So all that comes into this. So here we are trying to see that. So we know there are two terms, equality, health equity. What is equality? Already I told. Equality is something we are trying to give them the identical resources, but we don't know. We don't know that each person will have different needs. Without knowing the needs, we are just giving the same resources. Whereas health equity, we are trying to allocate the resources based on the specific needs so that the outcome will be same. Here the outcome will become same. Next. Next one. Next slide, please. So next one slide, we are going with we see that we have to ensure a proper opportunity to be given for the people, especially regardless of the social or economic or geographic background. That is more important, even demographic. So measurement metrics is very important here. We have to select the proper indicators to assess the outcomes, mainly they need to access the opportunity, they need to know the outcomes, also to process the equity. Like for example, the service, how much they are going to utilize the services, and whatever happens when they are becoming ill, when the people are dying, or when the service needs to be utilized, what is happening. So there should be a proper indicator. Already we know very well, vital signs, we know the death rate, birth rate, mortality rates, morbidity rates, all the indicators are there. So that is one important metrics. So metrics are more important. That is going to track the progress. Next one. So that is helping us to even go with the proper plans. Next slide. So after the measurement metrics, we have other things. There are certain things where we are trying to go with the health equity. So apart from the measurement metrics, there are certain principles, ethical principles that we need to follow. Like we need to see that the justice and fair treatment and autonomy should be completely given. So these are the very importantly ethical principles should be there in the health equity. Then only the ethicality and morality if you have, you will be going with the proper treatment. So this amendment is very important when we do a decision making, where we are trying to prioritize the needs of the people, especially the marginalized or the people who are deprived or who needs who are vulnerable, and also need to see that properly the resource allocation should be guided. Next one. Next slide. Next slide, please. So there are a lot of social determinants. I think we have seen earlier itself. We have told the social determinants, how it is going to be helpful. They are the pillars, which was already discussed. Next one. So here we know about the other things that comes under this. So we need to see that there are certain factors like income and employment, where we have to see that the income security is very important. People need to have a proper wages, job stability. So these are very important, because health. When we talk about health, where is the job? Without the employment, people cannot be peaceful. They need to have, without the money, nothing, without the budget, people cannot survive. So money is everything. So for money, they need to have an income and employment. So that will help to maintain the health. Similarly, also integrating the policies with the health programs are more important. That only can reduce a lot of deprivations, material deprivation, as well as it is going to help the population health. Next one. Next slide. So I think health equity, when we are saying, we are not talking about all this. We only talk about health, but we have to see all this now. Now we have to see this. So this is very important. This should be taken into consideration by all the nursing personnel. We have to see that we are trying to, first of all, maintain our own health. So with all this, so educational literacy, promote the literacy, try to go with the educational access. So all the learning, not only after learning BSc nursing, some people will stop. No, go with your MSc. After MSc, go with the PhD. Do postdoctoral. Try to improve your skills, because be tech savvy. So many things can happen. We should not. Age is not a barrier. Age is not an end. So we have to go with the proper learning to learn the skills, employability skills, entrepreneurial. Nowadays, nurses are becoming entrepreneurs. So entrepreneur skills, all that should be included. And also nowadays, the AI has come, ML has come. We are only talking AI, ML, but we don't know. Many of us don't know how to learn that. So that also should be learned. And similarly, the educational behaviors can be enhanced. A service can be completely enhanced. Also, the socio-economic mobility can be, long-term mobility can be enhanced only through education. Next one. So literacy is playing a very important role in the life of the people. So it can change many things. People can change. Individually, they can change. As a group, they can try to change. And environment, the safe housing, proper air, transportation is very important. Same time, we can see that any risk, environmental risk is there, we have to see it has to be assessed. Also prioritize the investments for the infrastructure, because sometimes people will be staying in a overcrowded place. The health will be affected. So we need to see that the infrastructure should be enhanced. So proper investment should be done. Also exposure and to any hazards should be reduced, and also a healthy living condition should be enhanced. Next one. Next slide, please. Okay, so policy and governance. So already we know very well the governance and policies are playing a very important role, where we need to have a legislation and regulation. So the law should be there, and this law. Next slide. So the law is going to govern everything. So the law is going to govern. So the law, there are a lot of laws. So now even ourselves in India also, I think many people are trying to have associations, and many associations are fighting for our wages, our salary, our position. So the law and regulations are very important, that can help to protect the vulnerable groups. Also, it is helping to guarantee equitable access. So the framework should be completely regulated, and standards should be enforced. Discrimination should be reduced, and also health goals. We have to go with aligning the health goals across the sectors. Okay, next one. Next slide. So the sectors, actually the social sector, economic sector, and also the environmental sector. That is what we mean by the sectors. So funding and resource allocation. So budget should be allocated. So that is very important. Then only we can go with the equity-based models. Equity-focused budgeting models are very important for the equity. Also, funding, sustainable funding should be done. Because what is sustainable funding? Because sometimes, the funding is given, and even the people who are highly privileged, higher class, they take the fund. No, underserved people should be targeted. So the spending should be fair resource distribution. So already the people who are having, if you're going to give to them only, again and again they will be gathering. And what will happen to the people who are deprived? Still they'll be in that portion. So in health equity, what we mean, we have to see that everybody comes and stand on the same pace. So we have to target on the underserved and also the underprivileged people, and the distribution of the resources should be fair one. Next. So the socio-economic conditions should be checked, and public-private partnership, already I told. So leveraging, that is very important, and this is very important because where the innovation can be encouraged. Also, it is helping to mainly target the marginalized populations who are deprived. Also, this is going to give a proper accountability, and it is helping to share the objectives. Performance metrics is very important because when we do a collaborative initiative, the assessment monitoring will become very much better because we need to monitor it, and that will help to track the progress also. Next one. This will fill the gap. Any missing gap can be filled with this partnership. Implementation strategies, that's what we need to see. A lot of implementation strategies are available, and we have to see that those implementation strategies are done. Next. So here actually I would like to tell some implementation strategies. When we see the action, so we are talking about the community engagement. Community should be taken, and of course, because we have to see that proper community, that it should be designed properly, decision making, we have to encourage, and evaluation should be done, and they have to be trustworthy and relevant people. So here the leadership, so local leadership should be support of them should be taken into consideration, and also the solution should be created, and also the sustainability has to be completely enhanced. So that's what is being done. So that's one thing, community engagement. Also, we have to see that next slide. We have to see that the mobile clinics, we can increase the mobile clinics because sometimes many problems are transport issues. So mobile clinics can be deployed. Also, the tech savvy, I was telling you, like we have to go with we have to leverage the tech. Leveraging the tech, it's very important because that is helping to mainly, it will help to reach the unreached. So leveraging the tech can completely fill the gap. And workforce and development. In workforce development, mostly we have to see that the workforce, the training should be given to the people. So the training is very essential, and the training and education will make the people to go with this equity principles they can follow. So continuous training, continuous support, and retention, especially in the underserved areas. We have to see that the experienced people should be posted there. Also, this is going to give a very good impact. It is helping to completely. So when a person is getting educated, posting them in the rural area and the tier 2 areas, what happens is we know very medicine and telenursing. So this kind of one, which is very much mobile clinics. It's trying to help the people, where the people can use the digital technology and they can access everything. So they can access the records, they can access. So already we have seen the universal health coverage, lot of digitalization has come. Ayushman Bharat and the clinics, and we have the schemes, all that. And these kind of digital mission schemes are all available that could be used. Next one. Next one. Next slide, please. Next slide. Okay, so monitoring and evaluation. Totally, we have to monitor the data, and we have to see the data, and we have to monitor the progress, and we have to do the adjustment. So that's what important. So without the monitoring and evaluation, nothing can be done. Next slide. So already, I think you can correlate with the SDG also, where we are talking about the same monitoring there also. So the same thing we can try to do. So here the key for implementation, we have to include the society. So social inclusion is very important. Inclusiveness, we were talking. So we have to see that the basic needs should be focused, health should be focused, gender equality. Coming to the economic growth, see that the decoupling growth. Decoupling growth is, we should see that the hazard should not be there. There should not be any hazard. Without any hazard, the growth should be fostered. So there should not be any problem environment, and the job infrastructure should be focused properly. In environment, that is planet, we are trying to go with the reducing the emissions. There should not be any emissions which is going to affect the people, and also the resources should be conserved. So let it be on the land or below the land. Next one. Next slide. Next one. Okay, so here when we talk about the one which I actually, here I'm not going to talk more on this because we have spoken on the core pillars. So the social determinants, already the resource should be distributed. Systematical justification of the resources are very, very important because there should not be any barriers, and health literacy. We should see that properly the community should be selected and the resources should be given to empower. So all this resource should be fair distribution. And same time, the social determinants of health is very important because the non-medical factors are playing very, very important role for the people because they need to grow, they need to, even when the people are born, they are growing, they are trying to living, they are trying to aging, they need to see that this particular non-medical factors will play a very, very essential role. So that has to be, so the neighborhood, friends, money, nutrition, your living condition, everything comes under this. Next one. Next slide, please. Next slide. Okay, so here you can see this picture. This picture is mainly on the equity. So this equity, how we are going to give the resource allocation, how it has to be done, and how quality can be enhanced, and how the cost containment can be done. So here we need to fill the gap. So the previous, I think Sir has spoken about the universal health coverage. I'm not talking on that. Just you can see this picture where we can see the how we can reduce. We can go with the financial risk protection, how the primary health. These, because nowadays we are targeting mainly on the primary care, and also the digital and affordability is very important. So nowadays all the three things like Ayushman Bharat, PMJ, BJP, also Ayushman Arogya Mandirs, also we have e-Sanjeevani telehealth services. These are the one which is helping the people digitally. People can monitor the records, monitor their own health, and they can also across the country and across the region they can take the treatment and they can try to go with the health services. Next one. So this is going to fill completely to fill the next one. So here there's a recommendations for the true equities. We have to strengthen the social determinants. Already we had told proper distribution, preventive care should be prioritized. And also when we're going to go as a nursing professional, we have to see that this kind of screening, the nursing professional has to screen. So research and development is very, very important. We have to screen the social determinants. We have to see there is any biases. We have to see whether the policies are implemented properly. Advocacy has to be checked. Also the barriers should be assessed. So the direct patient care, community outreach can be given, systemic and policy advocacy can be done by the nurses, and they can go with a lot of assessment. So nurses are very good in observation, very good in monitoring and evaluation. So we can do the assessment and we can give the recommendation to the country. Next one. So that is going to promote the health equity. So here, when we talk about the health equity, we can see it can be achieved when everyone can attain the full potential for health and well-being. So here, I think you can just click on the thing, no, because there is certain pictures. Okay, so we have to eliminate the health disparities. Already I told. So all the disparities. So let it be a social disparity, economic disparity. It has to be completely environmental disparity, demographic disparity, gender disparities that should be eliminated. And the landscaping and challenging is very, very important. All the challenges should be completely, we have to check. So then we have to go with the research. So the research and advocacy is very important part. And that only can help us because we know very well we have to go with the research, and also the science is very important. Like AstraZeneca, all they are trying to do a lot of researches, the clinical trials and the patents, innovations are more important. So the right move and right time is very important. Then only the health equity can be achieved by utilizing all these factors. Next one. Next slide. So coming to the conclusion, we can see the lot of take-home messages with regard to this. We have to see that the sustainable health development is very, very important, and sustainable development goals are very important. We need to be a part of that. Also, the equity is very important where we are trying. Can we go with the previous slides? Slide, the conclusion, previous one. Previous slide. Okay. So here we can see the SDG. I'm just telling about the SDG only here because very importantly next one. Next one, please. So yes, you're right. So here, SDGs are very important because we know very well the policy should be integrated. Sustainable financing is very important and robust data systems. That is all very much important. We cannot go with the preliminary ones. We need to be very thorough and it should be comprehensive. Also, the partnerships, innovations, also accelerating the measurable progress where we try to monitor and evaluate periodically. All these things are very important for achieving the 2030 agenda. So nurses are very important because they are in a very important position to improve the outcomes, especially in the underserved population, and they can work at any level because they can improve the structural factors, they can assess, and institutional factors they can assess, and they can try to completely fill the gap, especially in the disparities. And very well, we can see nurses can also utilize their expertise. Already I was telling, nurses are very knowledgeable. They can use their expertise and they can try to develop, and also they can try to advocate the policies and programs mainly to promote the health equity. Next one, next slide. So when we talk about the sustainable health equity, in sustainable health equity, whatever we do as a nurses, we need to see that we are completely trying to coordinate the policy, target the funding properly. We need to know how to fund, how to ask for the fund. Also, we need to see that the community partnership, we have to take rigorous measurement has to be taken, continuous improvement, we need to get committed. Also, we have to go with the voices. We should be a center marginalized voices because we need to voice out. Also, we have to use evidences, especially for the evidences are very important, mainly to take the investments. So SDGs are going to be a roadmap. It is going to help in bringing about a healthier nation, healthier country, healthier globe actually. So it's very equitable for future. It is going to improve the equitable future, and nurses are very indispensable and they are very important key professionals mainly who can realize these goals. And achieving the 2030 agenda is very important because actively everybody should participate, and also nursing professionals and worldwide they are a vast majority and they need to be leaders, and also they need to take up active participation in completely helping to targeting the goals and trying to achieve the 2030 agenda. Okay. So thank you. Thank you so much. So this is the one where we can go with the how to achieve the SDG and how to go with the health equity as a nurses. I think our young nurses nowadays. So these are the references. Our young nurses nowadays are very talented. They are very talented. I could see they are the leaders because it is taking I think the previously like us, it is taking a lot of time. It is taking I think our ages, we are just crossing our half century, and then only we are becoming little bit, we are trying to be assertive, we are trying to come out. But nowadays nurses are more assertive. So I think a little bit of experienced and experienced person, I request all the young leaders, young nursing leaders, mainly to completely take into this aspect, because today what we have taken today's conference, please don't take it as something like a certificate and just showing into the institution and utilizing it and just for the purpose of our renewal or the purpose of our job, retirement or retention or something like that. Kindly take this as a very important takeaway message and try to be an active participant for our complete target of this agenda 2030, and where we need to see that sustainable way we are trying to completely help others to meet this particular target. Okay, thank you so much. Thanks a lot. Thank you for the opportunity once again for the organizers. It's a great opportunity for me, and I think I have justified the session. Thank you. Any doubts if you have, you can ask. No doubts? I think everybody is tired because already two presentations are over.
Yeah, ma'am, your session was very good. So I don't think anyone is having any doubt. You have made each and every topic very clearly understood to each and every participant of this conference.
Thank you so much.
On the behalf of all the participants and on the behalf of the organizing committee members, I would like to thank you for such a wonderful session. You have guided us regarding the topic.
Thank you so much. Thank you for the opportunity once again. Thank you. Thank you for the organizers. I'm saluting the organizers and I'm saluting the audiences and the young leaders. And we are expecting a lot of change in nursing profession. I think everything is in your hands. Please do it. Okay. Thank you. Best wishes.
Thank you, ma'am. Next, I would like to call upon Prakash sir for the next session.
Yes, good afternoon, everybody. Am I
Good
audible, sir?
afternoon, sir.
Share.
Good afternoon, sir.
Good afternoon, madam. I'd like to share my slides. Okay, once again, good afternoon, everybody. I'll start my topic given to me today, healthcare inequalities in developing countries. So, to introduce healthcare inequality, it refers to unequal access to the quality healthcare services. Generally, we say that the conditions in the European countries and our Asian subcontinent are quite different. It affects millions of people in developing countries, and this poor healthcare leads to the preventable disease, disability, and death. And reducing inequality is essential to achieve the universal health coverage, that is UHC. Now we'll see what is the current scenario, that around 4.5 billion people worldwide, they are not getting the access to the essential health services. And out of that, low and middle income countries, that is LMCs, bear most of this disease burden despite having limited healthcare resources. Now we'll see what WHO defines regarding health inequalities, that health inequities are systematic differences in the health that they are avoidable through reasonable action and considered unfair and unjust. Because all the human beings are equal, and the developed countries get all the benefits of the what human has done the progress in the medicine and the nursing. On the contrary, the underdeveloped countries or developing countries are not getting benefit of this. So this is definitely, as WHO says, it is injustice to the people from the developing countries. Now, what we'll try to understand, what are developing countries? Developing countries are nations. We'll see their characteristics: low to middle income economies, then limited healthcare infrastructure, higher burden of communicable and non-communicable disease, as India is one of the greatest example, low human development index, then limited healthcare financing, that is again one characteristics, and shortage of skilled healthcare professionals. And the difference we can see, our Indian subcontinent, that is India, Bangladesh, Nepal, Pakistan, and the other subcontinent, that is from Nigeria, Ethiopia, Kenya, and Uganda. We'll see the types of healthcare inequalities. First, that is the geographic inequalities. So in geographic, urban versus rural healthcare access, that in our Indian subcontinent, if you know these countries, that we can experience, we have more access to the healthcare in the urban area, Why is rural healthcare? Nobody is are ready to go in the rural areas. Then limited services in remote and tribal areas. Though we are got independence since long, uh, certain regions like uh, Gadchiroli district in Maharashtra or Bastar and Datia in Chhattisgarh, for example, still they don't have any healthcare facilities, and to assess them, they don't have the proper roads. So they have to either come by some efforts like Doli, and they will sit in that Doli, and the poor persons will carry them to the nearest health center. Then economic inequalities, inability to afford healthcare. Now that becomes, you might have experience that in till last decade, as per my experience, it was affordable for even middle class to go to the private hospital, or beyond that there was a their home doctor was there, family doctor, what we say. And now we can see if a person is admitted for 2 3 days for example cardiac problem and something or angina, so the bill of 2 3 lakhs, it's obvious, it's not affordable. A high out of pocket healthcare expenditure, same. Then gender equalities. So almost we experience this in our country since beginning. So I will say it is in our gender inequalities in our blood only. So which is not fair. Unequal access to the maternal and reproductive health care. Because I'll give the other example that if you bring some green vegetable in a family, the children and the gents in the family, they will eat first, and whatever the green vegetable subji is there, a small portion will be there for the women's in the family. Next, gender-based discrimination. If the boy get ill, then the family will spend for him, and if the girls are female, they will try home remedies. That is our experience. Educational inequalities. So poor health literacy, already we always we quote that even a simple person, a normal person from the developed countries, they have the knowledge near about our nurses, about the diseases, disease condition, and all these things. Then limited awareness of disease prevention. So what we say, the primary, secondary, tertiary prevention. So we know that if it is a simple primary prevention, we can limit many diseases. Then social inequalities. This can be seen again in our country on a broader base. So these differences based on the caste, ethnicity, disability, and socioeconomic strata. About caste system, yes, we have to agree. We have a 4-tier caste system, and till few years back, untouchability was there. So they were not touched by the other people. So the medical and nursing care was a very difficult form there. Now this scenario is changing change fast, but still some parts of India may find this. And now about socioeconomic, we have a by and large three strata: high net worth income group, middle class, and the lower class. And this middle class has a largest this thing strata, higher middle class, lower middle class. So that is the social inequalities. Then digital inequality. Yes, we are facing these digital inequalities again, like urban and rural. That urban areas have more internet connectivity, and the rural, they don't get the signals even till today. Then reduce access to telemedicine and digital health services. Yes, it is there in India, telemedicine and digital health. Even robotic surgeries, remote robotic surgeries are there, consultations are there, but they are in the major cities, uh, and it has got a limited access. We'll see the current global statistics. The indicators will see population lacking essential health services, as we have seen in previous slide, 4.5 billion people, and then USC service coverage. So it is bit positive on a positive note that it increased from 54 to 71 in 2020 as per data of 2023. Then people facing financial hardship due to health expenses. So it is 26% as per the data of 2022. Low income countries health spending, so it is very less, less than 17 US dollar per person per year. So this figure can indicate the graveness of the low income countries health spending. Then minimum needed for essential services, US dollar 60 per person per year. So we can see the difference. It is, I think, near about more than a difference of 3 times. What are the causes of the healthcare inequalities? Number one is the poverty, then weak health systems, shortage of doctors and nurses, as this is seen in developing and even developed countries. Then inadequate government spending. So again, it is something related to political wish and will. Many countries, we have seen developing countries, we and our neighbor, they are spending much on the armed forces and arms and ammunition rather than the healthcare. Then poor infrastructure, yes, the road buildings we are lacking. Still, our hospitals are running in the British era building in the same filthy conditions. Political instability, yes, it can be there. Climate change, we are experienced this in last decade. Climate change, so we are experience the seasons, various season in different this thing. Now, for example, in many of the parts of the country, it is a still conditions are like summer, no rain. Then low health literacy, we have seen this low health literacy. People are not aware of the disease condition and their prevention. So again, the burden of diseases, it is increased. So major challenges we'll see. First is the financial. High out-of-pocket expenditure that we have seen in the last decade. I said earlier that the medical expenses are out of reach of the common people, and with my experience I will say that something like a loot is done by the hospitals. For example, last week my son was having food poisoning like that, and then it was a simple thing to have electrolytes or IV we took him to the private hospital where we are having health insurance, and they have made the bill of more than 5,000 just for food poisoning. Unnecessary tests were done about 3,500. So again, that is again one reason for the high out of pocket. Rather than just treating the condition, they are doing these blunders. Then limited health insurance, yes, that is that literacy is coming today. That is a positive sign. But the common people from the urban area and the even rural area, they don't know about the health insurance, or they cannot afford, the farmer class and the labor class. And the government services hospitals are there. For example, in Maharashtra, we have government ample government hospital, but due to the population, they have a lot of burden. So again, the healthcare is under the burden due to this. Then infrastructure, poor road, few hospitals, limited ICU bed, that we are facing everywhere. Then human resources, as I told earlier, shortage skilled healthcare workers are there. But again, in that shortage of skilled health care worker, I would like to quote, now many medical colleges are flourishing, like MBBS, and even the BMS are flourishing. Fake 100-bedded hospitals are shown throughout the year. Patients are not there. Just at the time of inspection, the patients are admitted on the daily wages. basis. Same the mushrooming of the nurses. I think I can quote the example from the Maharashtra. Every taluka place we have almost, by and large, we have the BSc Nursing College, A&M, and at the district place, then 5 to 10 BSc Nursing College, A&M, GNM, and we are not getting admission for the A&M. Sometimes it goes. So again, it is vice versa something. Inequal distribution between the urban rural area that we know very well in about the this thing knowledge about the disease conditions and the monetary basis. Then technology, limited digital health and telemedicine access. Still in India, we are having on the say pilot mode. We are having, for example, in Nagpur, the robotic surgery, and it is limited to one government medical college. Only one robotic arm is there, unit is working. So that is again the deficit. Now, the major what we are developing countries, we could not concentrate the important factor that is always neglected, that is the healthcare inequalities in maternal and child health. So we consider it is as a natural phenomena, that is obviously true, but we many times the actual medical aid is not taken at the proper time, or it is taken at the last time of delivery. So maternal health, delayed antenatal care, we see it as a natural phenomenon. That's true. Pregnant lady, she is not a patient, she is a mother, antenatal mother. But we took most of the time we took the help before the just delivery period. Limited access to the skilled birth attendant. Yes, this can be the problem. Not much in urban, but it is most prominent in the rural areas and the tribal areas. Most of the birth in the tribal areas are done by the experienced mothers, not the midwives. Higher maternal mortality, it is really a very sad thing. Then poor nutrition during the pregnancy. The same example I will quote, the lady is pregnant, green vegetable, 250 grams of the green vegetable is suppose cooked, and she will not get even 50 grams also. And how her hemoglobin will increase. So that is the uh, most neglected part in our some of the families, not all. Then child health. The major problem is again if the family is say um, have educational background, literacy, so immunization get completed. But still in rural and tribal areas, they do not think, or they will give some doses and they will miss some doses. And the another thing is that the our labor population, many of the labor population, they migrate from one area to this thing. One of the study was conducted by my one student about the immunization of these students. So the results were grave, that they were not having the knowledge and they were not bothered about the complete immunization. Then malnutrition, yes, it is there on the both the ends. The uh, uh, children from the high net worth families, rich families, and the poor families. So middle class have bit of the balanced diet and all this thing, but the poor families, they don't get proper thing to eat. And in the rich families, they have got ample access, but they will go for the pizzas and all this uh, such type of food which is having the junk, with what we can say Maggie and all. Yes, it is, access is limited. Then healthcare inequalities. Healthcare inequalities in disease burden. Am I audible, sir? Madam? Okay.
Yes, sir.
Okay. Then communicable diseases. We know all this: tuberculosis, HIV, AIDS, malaria, dengue. We have a large number of population having this condition, and though preventable malaria and dengue, we are still unable to control the malaria and dengue. Then non-communicable disease about the diabetes, and many times we quote in the classes while teaching UG and PG students that we one day will be India will be capital for this non-communicable disease such as diabetes, hypertension, and cardiovascular diseases. Mental health. Yes, this is the most neglected part in the developing countries. Uh, for example, I like to quote India again that we have got the medical colleges and then the district hospital, sub-district hospital, PSC, or a UPSC sub-centers for the physical health. But for the mental health, we are most of the time we are having regional mental hospital in the bigger cities, and there you know that the conditions are fatal. There are, suppose the capacity is 1000 in regional mental hospital, so there are more than 2000, 3000 inmates. So they are just eating and taking medicine there, but otherwise, ideally, no, the therapies cannot be done due to the burden. Then social stigma that is still there about the mental this thing. Like as a faculty of mental health nursing, I appreciate our ancestors. About their some person was having a mental health problem, they be used to correlate with him godly, that this person is a godly. So nobody used to trouble. I have seen that in my childhood. So they used to say that the God has given uh, something to him. He's differently abled. Word we use, and everybody used to respect these persons having the uh, mental retardation and all these things, major thing. But again, the now the scenario has changed. That social stigma is still there. Though we are doing so much of propaganda, but that is not going away from the mind of the people. And shortage of trained professional. Yes, we have to agree that we don't have psychiatrists in a proper number. We don't have psychiatric nurses in this. And one irony I found in Maharashtra, I don't know about the other Indian states. In government setting, if some general nurse, the nurse who has done uh, general nursing or BSc nursing, and if she is doing 1 year diploma in mental health nursing or MSc in mental health nursing, she will be posted as a psychiatric nurse, and she will get increment in that. But from that day, because that is the level to the ward in charge post, and the salary difference is also there. But instead of taking care of the patient, she behaves like, or she stays there as a ward in charge because she is having red belt that time, and now we have got the batches because the dress is changed. That white frock and white sari is not there in government of Maharashtra nursing services. We have salwar kameez and the apron. So that is a very sad thing. We say one time shortage of trained professional. On the other hand, the trained people, they are, instead of taking care of patient, like cardiologists, they will take care of the patient with the cardiothoracic problem. But our nurses, they will sit in a separate cabin as a ward in charge. So that is a sad thing. That is a practical thing I am like to quote. Then what is the impact? First, we'll see health impact, increase morbidity and mortality. Yes, that is clear. Even in the non-communicable diseases like diabetes and cardiac conditions. Then delayed diagnosis and treatment. That's a problem in the developing countries, that in all the developing countries here and in the uh, African countries, for example, we take delayed diagnosis and treatment, we have the parallel system in our countries, developing countries, that our what ancient knowledge is there. So rather than taking the treatment, we'll go for the home remedies and all these things, and then it becomes very late. And still, we believe that if we'll take some Ayurvedic kada, heart disease will go away. Take some tablet for 60 days, your diabetes will go. All rubbish things are there due to this. Then the obviously reduced life expectancy, which is against our developing countries' policies, and we achieved to much extent, but I think we are coming back or what. Economic impact, yes. Catastrophic healthcare expenditure, that is there, yes. Loss of income and productivity due to the ailments or diseases. Social impact, increased poverty, poor educational outcomes, and reduced quality of life due to this inequality. Current situation, India, the major challenges, I think, rural-urban disparities in healthcare. I think told this 2-3 times, rural-urban, and we experience this all the time. Urban people get all the facilities about the health, and rural, they don't get even a paracetamol when they get the fever. Then shortage of healthcare professional in rural areas. Yes, I told earlier the healthcare professional don't want to go to the rural areas. If at all they go, the real picture is that they will do up and down from their town, or they have a limited days. They will go on Tuesday and then they will come on back on Friday, 3-4 days duty, and it is accepted in at least Indian setting, because they are staying in the not the facilities are not there in the rural areas or villages. High out of pocket expenditure, we have seen this. Malnutrition among women and children, yes, it is still there. Limited healthcare access in tribal population, that is a very I stay in Nagpur, so just 150 kilometers from here we have the this thing tribal areas, and still the conditions are like the Middle Ages, that communities, they still do not wear much clothes. They will just wear a cloth as undergarment, and both the so that is the condition of the clothing. So rest forget about their healthcare access, because the road are near, network is not there, nobody is trying to go there. And on the other hand, we say that healthcare personnels are not going, but I have gone to that areas, no network, and if if there is a rainy season, you cannot come to the urban area for at least then 2 months. Connectivity is not there in that area, so it is difficult to stay as a healthcare professional in this, especially tribal areas. No schools, so all the problems for the healthcare personnel and their children. Then government initiative, that is a silver lining in a cloud, I will say like that. We have Ayushman Bharat, that all of know. Health and wellness centers are open everywhere. For example, Delhi, I can quote Mohalla clinics. In certain area, they will have a particular area, they have clinics. So that is a good idea. Then NHM, that was previously it was NRHM. Now it is for both rural and urban area, and that is doing very well. Ayushman Bharat Digital Mission, yes, it is doing well. And one of the this thing, major part of the people was going on medicine. So now that is a Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana. So in that you can get medicine in a reasonable prices. Now the strategies to reduce the healthcare inequalities. So strengthen the primary healthcare service. As I told that urban areas, we know urban areas has a bit better this thing. So strengthen the primary healthcare services. Increase the government healthcare expenditure. Again, the political will is required for that. And in Indian setting, the history says that we have always underperformed in the um, uh, like for the expenditure budget for healthcare. Then achieve universal health coverage. Yes, that is the right thing. Improve rural healthcare infrastructure. Uh, that is a good initiative that can be there by the government. Expand health insurance coverage. That is, I think, one of the best. This thing, even I was not aware. I was knowing, but I have not taken the health insurance just 5 years, still 5 years back. And then I told that I was working in a government setting, state government setting in a government medical college. So we used to believe the government medical colleges, but last 5 years, due to the tremendous workload, uh, the now the healthcare in the government setting, it is under burden. So I have to opt for the health insurance, and the results are better that at any time you can go for any private hospital, good hospital. Then train and retain healthcare professionals. Uh, that is still going on. I said mushrooming is going on. Promote health education and awareness. Yes, that is the very, I think it will not take much, it do not require much money as compared to the health infrastructure and medicine, all this thing. So this will reduce a burden like primary prevention uh, and the side effect of the drug and all this thing if the people will aware of the diseases. Improve transportation and emergency services. Yes, now it was few in the last decade we were not having these services. For example, take example the ambulance. Now in majority states of the India we have 108 national number and the ambulance at your doorstep within few minutes. Then expand digital health technology. There is a lot scope for that. In the Nagpur, we have experience. We are in government medical college. We have the robotic surgery unit, and the surgeons from here they have operated in the various cities, sitting in the Nagpur, or the surgeons from the other cities they have operated in the Nagpur. So digital health technology, it has a good future. Then encourage community participation. Yes, without community, we can not do anything. Then I think I'll not take this part much because Madam Vasanta Kumari has taken this topic well. So that will be a repetition, I think. So I'll skip this topic. Future challenges we'll see in a nutshell. That rapid population growth, that is yes, the statistic shows that we'll go ahead of China in the population growth. So that is a really challenge. Climate change and environmental health risks. Yes, we are experiencing this in this decade. As per my personal experience, at once time there was a summer, winter, and rainy season. Now the seasons are the mix. In Nagpur, there is again heat like summer. You have to sit in AC or the coolers. Then emerging and re-emerging infectious diseases, that is a matter of concern because now we are having increased literacy and out of that again it is a question mark for me also why this re-emerging of infectious disease is there. Then antimicrobial resistance AMER, that is the most problem of the most uh, developing countries. I don't know much about this antimicrobial resistance in other countries, but India self-medication and taking the not taking the antimicrobial for a proper dose of 3 days, 5 days. Just take 2-3 tablets of the antimicrobial or antibiotics. If the patient feels well and he stops it, he keep that strip with him. Again, the problem comes, he take out up to 3 tablet out of that thing. So that is again the not only antimicrobial resistance, but lack of knowledge about the medication and their side effect. That is, I think, the key factor. Then increasing burden of non-communicable diseases. So that is actually, it was non-communicable diseases in a era we have experienced. They were in a limited number, but due to the new lifestyle, addition of the junk food like pizza, Maggie, for example, that has increased the risk for non-communicable disease like diabetes and cardiac condition. Especially, I go to any city everywhere in India. I like to roam here and there. So I see the outside food, street food is much, and with the Swiggy and Zomato, majority of the times the youngsters, especially, they are ordering this food from outside, and empty calories are there, and uh, junk food, it has increased the risk burden of non-communicable diseases. Then shortage of healthcare workforce, yes, it is the still problem there. Then health misinformation, that is the great problem in the developing countries. Health means misinformation as two edges. It is a dual edge, I will say. Health means not having the health information of the modern medicine and the nursing is one edge. The other medicine, our home remedies. Home remedies are there in India, but they are limited to the minor ailments. Yes, they are. I agree. I am from the same socio-cultural background. That yes, they are useful for minor ailments, but we are using for a cardiac condition, jaundice, diabetes, and the advertise are there. Take over 30 tablets, 60 tablets. Diabetes gone throughout your hypertension is gone with our medicine. So that is the problem. That is a dual edge. Limited healthcare financing, yeah, that is a problem from the government agencies also. Next, we'll take recent WHO updates. So, WHO emphasizes that preventable health gaps are driven by unequal access to education, housing, employment, and social protection, and that is the fact. And WHO has expanded its health inequality data repositories, providing disaggregate data from nearly 200 countries to better monitor inequalities. But the WHO, all have seen they are doing very work very well in all the countries. They are giving the guidelines, but as we have seen the causes, the political shifting and the war, and they are taking some of the countries to the like Sudan, say Palestine, Gaza. So though guidelines are there, they are going back and back. If the remaining thing is there in a stable countries, the government will not give the is not able to give the proper infrastructure and financial aid. Okay, next we'll see the recommendation and we'll try to conclude the session. So all the uh, participants, so I'll not make you much bore. I'll conclude it in a few slides. So recommendation, increase government health spending. Uh, that is like to have a bail in a cat's. Yeah. Strengthen primary health care. Yeah, that is the important thing, primary health care. So at the base area only, you can control the diseases. Expand universal health coverage. Yeah, that is the real goal. Improve rural healthcare infrastructure. Like a country like India, which is the majority population is rural, and even we are unable to provide proper healthcare to them. Increase healthcare workforce. That is the one of the recommendation. Promote digital health and telemedicine. Reduce out of packet expenditure. Strengthen public-private partnership. So now we'll conclude the session that healthcare inequalities remains one of the biggest barrier to achieve universal health coverage. Although progress has been made, billions of people still lack essential healthcare. That is a really sad thing. Some people are getting good healthcare and some are not getting. Stronger health system, equitable financing, and investment in primary care and the health workforce are the essential to reduce disparities and improve health outcomes. So here I conclude this lecture. I thanks to all the participants. You are listening my lecture. I tried to do it in a shorter period because nobody likes a boring teacher. They want in a short this thing. And again, I'll give my thanks to the organizers, especially Manisha Agrahari madam. And here I conclude with this my speeches. Thank you once again.
Thank you, Prakash sir, for this wonderful session. So, without delaying, we will move on to the next speaker. And the next speaker is Dr. Annapurna Reddy, ma'am. She is a Vice Dean of Integral University, Lucknow. Ma'am, are you available? Annapurna, ma'am. Annapurna, ma'am.
Ma'am, kindly unmute yourself. Annapurna, ma'am, kindly unmute yourself.
Yeah, am I available? Thank you.
Okay. Sure, ma'am. So I will share your, yes, ma'am.
Yeah. Please share my screen.
Yes, sure, ma'am. Technical members, kindly just sir, yes.
Yeah.
Yes.
I'm
Sure, sir.
Yeah.
I will share Annapurna ma'am's
Yeah.
PPT now. It's visible, Annapurna ma'am?
Yeah, it's visible.
Okay, ma'am.
It's visible to audience as well, I believe.
Yes, ma'am, it is visible.
Okay, thank you. So very good afternoon, one and all, and thank you for joining. It's a genuine privilege to be with you all today. So myself, Dr. Annapurna, I'm working as a Vice Dean in the Integral University, Lucknow. Today, I'm going to explore with you all the topic is community-based nursing care or CBNC. And why I believe it's one of the most consequential strategies we have for closing the gap in health access worldwide. We will move from the scale of the crisis through the conceptual and evidence-based into a concrete strategies and workforce needed and arrive finally at a vision for the universe health coverage. Next slide, please. So before we dive in, let me give you a map of where we are headed. There are 10 sections in total. I'll move through them in a deliberate order. We will begin with the global health context and crisis, then move into the conceptual framework of CBNC. From there, we will look into the innovative strategies and digital tools and evidence, followed by the community empowerment and cultural care. And then we will turn to the nursing workforce and leadership, research frontiers, and policy advocacy, and how the implementation actually works, moves from the strategies to practice. And finally, we will look at the impact metrics and case studies and the challenges and the recommendations ahead. And and close with the universal health coverage. Next slide. Let's start with the scale of the problem, because I think it's important we sit with these number of a moment before we talk about the solutions. So the nurses make up 59% of the global health workforce, and yet we are stretched thinner than ever. By 2030, we are projected to face a shortage of 5.9 million nurses. That is 8% of countries already reported critical shortages. And perhaps most sobering of all, 94% of maternal death occur in low-income nations, and death that are in large part which is preventable. And this image, which shows us overcrowded hospital in the world, it is not an isolated snapshot. It reflects a system under sustained strain, which is globally. And I leave you with this quote from the WHO: the global nurses shortage is not merely a workforce issue, it's a humanitarian crisis demanding immediate, coordinated, and evidence-driven action. So this sentence in many ways, which will have the, I'll share with you all today. Next slide. Now let's unpack these inequalities actually come from. So first, maternal mortality, 94% of these deaths occur in low resource settings, and critically they are largely preventable with skilled nurses care alone. Second, rural healthcare access, where the distance from specialists mean delayed diagnosis and consequently high rates of complication. And third, the rising epidemic of non-communicable diseases, that is diabetes, hypertension, cardiovascular diseases, which are climbing fastly among the most disadvantaged population. And this photograph shows a community healthcare worker who is counseling a mother and child in Africa. So I include it deliberately. Behind every statistics I have just given you is a real relationship and the real conversation happening in a real village. Next slide. So continuing with this picture, there are three more disparities nurses confront daily. That is the mental health gap, which is widening due to a stigma and lack of community level support systems. And the child malnutrition, 149 billion children globally are affected by these stunting, and nurses are typically the first line of response for this. And geographically isolation, where the rural and remote populations often lack even the most basic primary healthcare access. So where does this leave us? So I would suggest it leave us with one clear conclusion, that is addressing these disparities, which requires the delivering care where the people actually lives, not only where the hospitals happen to be built. And that idea is exactly what brings us to our next section. Next slide. The health equity, which means that everyone has a fair and just opportunity to be as healthy as possible. So it requires the actively removing systematic obstacles such as poverty, discrimination, and inadequate access to care and education. As you can see in this diagram, health equity sits at the intersection of these 6 domains, that is a universal health coverage, sustainable developmental goals, economic productivity, social justice, and human rights, community resilience, and at the center of all, the nursing leadership. I want to underline something here. Healthy equity is not only a moral imperative, it is an economic one too. And the nursing leadership sits right at the center of the achieving it. Next slide. So this charts gives us a very concrete picture of burden where we are discussing the nurse density by region according to the WHO data. So the North America sits at the top with 83 nurses per 10,000 population, whereas the Europe follows at the 73, then sees the steep drop where the Western Pacific at 41 and Southeast Asia at 20 and the Eastern Mediterranean at 16 and Africa is just 11. Look at the gap between the Northern America and Sub-Saharan Africa. It is an 8-fold difference. And the consequence of that gap in human terms is this 2.6 billion currently lack adequate nursing care. So that number 2.6 billion is really the problem. This entire talk is trying to solve this. Also, let's turn now to the model. I I believe we can help close it. Next slide. So what exactly is community-based nursing care? So in the simple terms, CBNC, it delivers the comprehensive healthy care within the community settings, and it is emphasizes the proactive outreach over reactive treatment. It's not only about waiting for the people to become sick or enough to seek us out. It's about the going to them before that point. And this diagram shows that the CBMC rests on 6 pillars, that is health promotion, disease prevention, early diagnosis, rehabilitation, continuity of care, and community empowerment. I would like to hold on these 6 because everything I present for rest of the talk. So every strategy, every workforce role, and every metric which will maps back to one or more of these pillars. So be attentive. Next slide. So I find this comparison particularly which is useful because it captures the paradigm shift where really we are talking about. On the left side, the traditional hospital model that is reactive, urban-centric, high-cost, episodic, disease-focused, and frankly inaccessible to the remote populations. On the right side, if you see, community-based nursing care, which flips each of these. It's proactive and it reaches rural and remote communities. It's cost-effective and preventive by design. And it treats the whole person biologically, psychologically, and socially rather than just the disease. So I won't walk through every single contrast of this slide, but I would want to highlight one. That is, traditional care is a provider center, meaning like decisions are made largely for the patient. Whereas CBNC is a person-centered decisions are made with the patient. That shift, in my view, is where the real transformation begins. Next slide. Now I want to clear that CBNC is not a passing policy trend. It's grounded in the decades of the nursing science, and I would like to briefly name the theoretical models that underpin it. We drawn on the primary healthcare model from the WHO and UNICEF since 1978, according to Alma Ata Declaration, which is the first established community health as a foundation of all healthcare systems. And the social ecological model from Bronfenbrenner and Green, which examines how individual, interpersonal, community, and policy factors will interact. Next is Nightingale's environmental theory, as it is very first systemic nursing theory, which emphasizes the role of environment in recovery. The community as a partner model from Anderson, which treats the community itself as a client. And the health belief model from the Rosenstock, which predicting behavior through the perceived risk and benefit. And transcultural nursing theory from Medlin, which is essential for culturally congruent care in global context. So together, all these 6 models, which allows me to say with confidence that is CBNC is an evidence-based, not improvised. Next slide. Let's move into the section 3, that is innovative strategies. So here we have the our first strategy, that is digital community health nursing and telehealth. So the technology-driven interventions are genuinely revolutionizing how we reach underserved population. The AI power risk assessment use predictive algorithms to flag the high-risk individuals before any acute episode occurs. And the mobile health apps also supports the maternal and child tracking, medication adherence, and chronic diseases monitoring, as well as the tele-nursing consultations. They will bring the remote specialist level guidance to all the rural community via smartphones. And electronic community records, which will enable continuity of the care and population level surveillance. And remote patient monitoring through the wearables and biosensors, it will allow the continuous vital sign tracking outside the hospital. And the digital health literacy programs where the nurse-led help bridge the digital divide and build trust in the technology-enabled care. So these research is comparing where the telenursing intervention significantly improves the medication adherence, diabetic control, and the patient satisfaction in the rural communities. Next slide. Let's zoom it in, specifically on AI now. This is the part one, which will comes the next slide as well. Think of it as a pipeline. So the data collection flows into the AI processing, which enables the risk satisfaction, which then guides the nurse intervention, and finally outcome monitoring. So I want to stress the point here, AI augments the nurse's judgment here. It does not replace it. So the three applications on this slide, that is disease outbreak prediction, where the machine learning analysis community data to detect emerging clusters days before clinical presentation. And this patient risk satisfaction, where AI engines score chronic diseases patients by complexity, so the nurses know exactly who to prioritize for a home visit. And the symptom check chatbot offering 24/7 AI driving triage that guides community members through assessment and towards the right care pathway. Next slide. So it will continue the AI strategies, applications. Next is the smart wearable integration, where continuous monitoring will detect the deterioration in the real time and alerting the nurses before an emergency escalates. Medication adherence AI. It will using the smart dispensaries and reminder systems to reduce the non-compliance in conditions like hypertension and diabetes. And NLP documentation tools, which will automatically analyze the nursing notes to flag documentation gaps and quality indicators. So I want to close this part of the discussion with an caveat because I think it's an essential, any ethical framework of AI in nursing must center data privacy, algorithmic equity, and community trust without any foundation. Next slide. Let's move to our next strategy, that is evidence-based community nursing practice. If the strategy one is about the technology, extending our reach, then the second strategy is about the rigor grounding everything we do in sound research and genuine clinical expertise. So this is the EBP cycle. It moves through the 6 steps. We ask a clinical question that acquire the best available evidence, appraises its quality, and then apply into practice, and then audit the outcome. And finally, we have to adapt and improve the things. The critical point in this linear, like it is a cycle, each round of the practice will generate new questions, which will send us back to the step 1. So on the right, if you will see the research streams that feed this cycle, community needs the assessment, RTCs on the health education effectiveness, rural versus urban comparisons, social determinants, research and cost-effective studies, and longitudinal chronic disease studies. Next slide. This is the payoff slide of strategy 1. The actual evidence behind everything I have claimed about the digital nursing. This data comes from the meta-analysis of the 47 tele-nursing studies across 23 countries from 2018 to 2024. The results, that is a 34% increase in the medication adherence and a 28% improvement in the diabetic control, as measured by the HbA1c, and a 42% rise in the patient satisfaction. On the cost wide, we have seen a 31% of reduction in the hospital readmissions. It's a reduction, that is hospital readmissions, and 25% reduction in the emergency visits. And perhaps most striking of all is a 67% expansion in the care access reached. So I want to be direct about what this means. The digital nursing strategies are not speculative. They carry a robust multi-country evidence base behind them. Next slide. So let's turn now into the section 4, that is strategy 3, that is a participatory community empowerment. The central idea here is simple but powerful. When the communities themselves participate in the healthcare delivery, we see higher immunization coverage and better chronic diseases management. So there are 6 mechanisms at the work, that is community health volunteers who bridge the healthcare system and communities through education and referrals. Peer support groups offering structures and mutual accountability networks for chronic disease patients. School health ambassadors extending the health messages through youth-led programs. Then women-led initiatives which will drive in the maternal health and nutritional education. Next, faith-based partnerships. They were delivering the trusted religious institutional for health messaging. And the participatory rural appraisal, where the community identifies their own priorities and co-design solutions, which building the genuine ownership, not top-down the compliance. Next slide. Our fourth strategy, that is the nurse-led preventive healthcare clinics, which is staffed by the advanced practice nurses offering cost-effective and accessible primary care. So these clinics cover 6 service lines: hypertension and cardiovascular screening, diabetes management, maternal and child health, cancer screening, geriatric care, and mental health counseling. And at the outcomes speak for themselves, a 40% of reduction in the hospital admissions. These clinics being 3 times more cost effective than conventional care. And 92% of the patient satisfaction is there. And also 58% improvement in the diabetic control. These are not the modest numbers. They represent a fundamentally more efficient model of the primary care. Next slide. We now move to the section 5, that is nursing workforce and leadership. And I want to open with a simple but important reframe. Investing in nurses is investing in healthcare system. Investing in nurses is investing in a healthcare system, that is overall. On the education and training side, and our priorities are mainly expanding global nursing training capacity, building community nursing competency frameworks, adopting interprofessional educational models, ensuring continuous professional development, and investing simulation-based clinical training. I close this slide with a quote from the WHO, that is in 2020. Empowered nurses are the single most scalable solution to closing the global health gap. Next slide. Training nurses is only half the equation. Retaining them, sustaining them is the other half. And frankly, it's too often we are neglected. 5 levers matters here. That is rural service incentive programs, competitive career pathways, supportive supervision system, mental health and well-being support, and for nurses themselves, and safe staffing ratio legislation. I want to be candid. Burnout and attrition can do years of training investment. If we don't address these retention factors, Alongside recruitment, it's not enough to train more nurses if we can't keep them. Next slide. Let's look now how far advanced nursing practice can extend what community nursing accomplishes. So we have the nurse practitioners who manage over 75% of the rural primary care visits independently, that is in the US. Clinical nurse practice specialists serving as educators, consultant, and evidence translator in specialty areas. The certified nurse midwives who completes maternity care can reduce the maternal mortality rate by 30% in low resource settings. And the nurse anesthetist administering the anesthesia independently in over 80 countries where the physician anesthetists are scarce. And public health nurses focused on population level surveillance and the policy implementation. At last, the community health nurse specialist, the strategic architects of the CVNC at scale. So here we are expanding the advanced practice nurse scope of practice is among the most evidence supported policy levers we have for achieving universal health coverage. Next slide. So this slide brings together a theme I have touched on throughout, that is the shift toward people-centered care across 3 dimensions. So here the first dimension, patient empowerment. Individuals as active architects of their own care through shared decision-making and health literacy. Second, family and community engagement, treating the families and social network as essential support system, not bystanders. And the third dimension, continuity of care. Sustained therapeutic relationships spanning prevention all the way through to end of the life care. So I would like to notice this echoes of our earlier comparison slide. Person-centeredness is not a valuable statement what we make. It is a structural design choice we build into a system. Next slide. So we move into the section 6, that is research frontiers and policy advocacy. So let's begin with the 4 emerging research dimensions. AI and predictive analysis. So here we can apply the machine learning to outbreak the prediction, risk satisfaction, and resource allocation. Next, mental health and resilience, including the community resilience frameworks and post-pandemic psychological interventions. Next, climate change and health. Here we covers the climate sensitivity diseases and disaster preparedness, especially in the nursing. And the migration and refuge health, which addresses care for displaced population facing both infectious diseases, risk, and trauma. So these 4 represents, in my view, exactly where the community-based nursing care research needs to expand next. Next slide. So I want to talk now about something. Next slide, please. Next slide. I think it's previous. Slide number 23, can you open? Yeah. So I want to talk now about something I feel strongly about, the modern community nurses professional identity, which I would describe as 4-fold. First, generating evidence, conducting community-based research, identifying disparities and publishing the findings. Second is translating research, which is converting findings into clinical guidelines and frontline education. Third is advocating for policy using evidence to influence legislation and resource allocation at national and WHO and SDG goals levels. And fourth is mobilizing communities, leveraging a nurse community trust to drive collective health action. Next slide. So let's connect the CBNC directly into the Sustainable Development Goals. Previous speakers, they already taught about the SDG goals, which is included in the nursing. So which included in the community, that is SDG 1, 2, 3, 4, 5, 13, and 17. So the first one is the no poverty, where the community nurses connect families to social protection and economic empowerment resources. SDG 2 is zero hunger, nutrition surveillance, malnutrition screening, and breastfeeding support. SDG 3, that is good health, direct delivery of universal health coverage, maternal and child health, and NCD management. SDG 4 is quality of education, health literacy program, and school health nursing. And next slide. Next, SDG 5, that is gender equity, addressing the maternal mortality and productive rights. SDG 10 is reduced inequalities, targeting underserved population and equitable resource distribution. 13 is climate action, climate sensitive disease management and disaster response nursing. And 17 is the partnerships where the international nursing networks and across the sector collaboration. So this section, the line I think captures its best. The nursing functions as the connective tissue that translates global commitments into local and measurable change. Next slide. Now let's turn into the something very concrete, that is 6 evidence-based policy recommendation for government, health ministries, and global organization. The prioritizing primary healthcare funding at least 15% of national health budgets, which dedicated CBNC funded lines. Enhance nursing education, that is standardized competency-based curricula with mandatory community practicums. Expand scope of practice, that is authorizing advanced community nurse to prescribe, diagnose, and let the care team independently. Next, integrated digital health. It's mandating the telehealth in rural areas and funding digital literacy. Next, invest in workforce planning. 10-year national plans with rural incentive packages and increase the, next is research investment. Allocating 5% of the health R&D to the nurse research and establishing national nursing science institutes. So these are all not the aspirational statement. There are actionable policy asks, and I would encourage anyone in this audience with the policy influence to take them seriously for all the future nurses. Next slide. And let's move to the section 7, how to implement actually happens in practice. The cycle runs through 5 phases, that is situation analysis, where we conduct a community needs assessment, program design, that is selecting an evidence-based model. Next is implementation, that is deploying the nurses team, and the monitoring and evaluation, tracking KPI through and dashboard, and finally scale and sustain, replicating the program to new communities. Just as with this evidence-based practice cycle earlier, I want to stress this like monitoring and evaluation data feeds directly back into the next round of situation analysis. These programs should be understood as continuously improving, not launched once when it left alone. Next slide. So it's about the technology backbone which is required to support CBNC at scale. So that is data collection, mobile health apps, wearing biosensors, community health record systems, paper to digital tools. Next, connective 4G, 5G networks, satellite connectivity, offline first apps that will sync when the connection returns. Next is analytics, which includes the real-time dashboards, predictive AI models, and population surveillance. Then decision support, which includes the clinical algorithms, drug interaction checks, and evidence-based care pathways. Finally, governance, data privacy legislation, cybersecurity framework, interoperability standards, and ethics oversight. I have placed governance a last quite deliberatory infrastructure. Without governance is a liable, it's not an assist. Next slide. So effective community health is never a solo effort. It requires a coordinated team, and this diagram shows the community nursing team functioning as a hub. So around that hub, we see the physicians, specialists, pharmacists, laboratory services, social workers, and counselors. And also the public health officers, community health volunteers, NGOs, faith groups, government partners, and coordinating around the nursing team. So, and here the data that proves the point: effective interdisciplinary team achieves the 28% better health outcome than siloed care model. That's not a marginal improvement, it's a sustainable one. Next slide. So next it is an impact metrics and case studies. And I think the best way to demonstrate impact is through real examples. So let's look at these three spanning 3 continents. In Kenya, mobile nursing clinics, it reduces the maternal morbidity by 45% by delivering the antenatal care and safe delivery directly to the remote communities. Whereas in India, the ASHA community worker program, it delivers diabetes and hypertension management across more than 640,000 villages. And in Brazil, the family health strategies, which uses the multidisciplinary nursing team to provide comprehensive primary health care directly in people's home, which achieving the 70% of the population coverage. So these 3 examples matter because they show community-based nursing care working across very different health systems in income levels as well as the geographies. Next slide. So I would like to zoom in now on India specifically. Since it is the world's largest democratic community health system, I think it's offer particularly rich lessons. The ASHA worker network has trained and supervised over 1 million community healthcare workers under public health nurses. And this is described as India's most successful maternal and infant mortality intervention. And the Ayushman Bharat is in India USC scheme, which build the health and wellness centers staffed by the nurse-trained community health officers. And the post-COVID, if you see, the Sanjeevani telemedicine platform has facilitated over 100 billion teleconsultations with nurses as the very first point of digital contact. But I want to be honest with you, this is not a story without challenges. A 50% of nursing vacancy rate in rural primary health centers, urban-rural maldistribution, and low public health nursing enrollment all remain real and unresolved problems. Next slide. So the next slide, I would argue the strongest evidence slide in the entire presentation, that is systematic review of over 200 community nurses studied across 40 countries spanning to 2010 to 2024. Let's walk through this comparison. That is, hospital admissions drops from an indexed 100 to 72, that is 22% of reduction. Next, emergency visits drops from 100 to 78, that is 18% reduction. Next, medication adherence, it is rises from 60 to 88. The patient satisfaction rises from 70 to 93. Care cost per patient drops from 100 to 82. That is a 25% cost reduction. And the chronic diseases rises from 55 to 80%. That is 28% of improvement, which I would like to highlight specifically since it is called out of the slide. I would consider this the evidentiary climax of the talk, and everything before this slide has been building towards this evidence, and everything after it will build it on. Next slide. So, having shown you this evidence, I want to be equally honest about the barriers that stand in the way of scaling CBNC in this section. Among the high severity barriers, the workforce shortage, that globally deficit is 5.9 million nurses, worsened by the migration to high income countries. Next, resource scarcity is less than 1% of global health aid currently reaches LMIC primary healthcare. And the policy barriers, restrictive scope of practice legislation, and lack of formal recognition for community nursing boards. Among them, medium severity barriers, that is the digital divide, limiting healthcare adoption where the smartphones and connectivities are scarce. And the research practice gap, which is given limited implementation, science capacity in many low and middle income countries, and the occupational stress, burnout, moral distress in high equity, and low resource environment. Next slide. Next slide. Let's now look forward. '34 slide, please. This is my vision of community nursing, that is 2030. A landscape powered by empowered, digitally enabled, equity forced nurses. The digital community care where every nurse is equipped with the smartphone-based clinical decision support. And universal primary healthcare coverage with community nursing team deployed with 5 kilometers of every household. And the nurse-led health system with advanced practice nurses leading primary care and prescribing independently. Next, equity center research where the low and middle income countries generate 50% of global community nursing evidence, directly shaping WHO and SDG policies. Next, AI augmented practice, amplifying, not replacing, nursing judgment, and the resilient systems will build to withstand pandemic, climate disaster, and conflicts while maintaining essential care. So now we arrive our final session, that is universal health coverage and conclusion. And I want to position this community-based nursing care as precisely what the title says, that is the cornerstone of UHC. UHC rests in 3 dimensions, that is access, ensuring every person reaches quality health service without geographical, financial, or social barrier. Next is quality, which is delivering safe, effective, person-centered, timely, and equitably care in every single interaction. And last is financial protection, where the CBNC reduces cost by 15 to 20% through prevention, shielding families from catastrophic healthcare expenditure. So that the path forward, these 3 steps. First, bridge gaps, reaches 2.6 billion people left behind by traditional health systems. Second, embrace the innovation, harness digital tools, AI, mobile health to extend nursing reach. And the third is to achieve the UHC, make it a lived daily reality, not a policy abstraction. So let me bring this to close. That is, a community-based nursing care represents a transformative, evidence-driven strategy for addressing the global health inequalities, one that genuinely improves the accessibility and outcome for the world's most vulnerable population. I have organized everything and I have shared today around these 4 themes, that is innovation, embracing the digital health, AI, telenursing, next evidence, that is grounding every intervention in research, equity is in centering the needs of most vulnerable, and the leadership, nurses as architects for health policy, not merely providers of care. So the time is to act is now, and the nursing professions is already ready. So thank you so much for everyone, your time and attention for today, my session, and I would be delighted to take your questions. Is there any queries from the audience side?
Thank you, Annapurna ma'am, for this wonderful session. And really, I'm very thankful to all the participants and especially all the guest speakers, so that they have made the first day of conference very well. They have explained each and everything very nicely. And so tomorrow will be the second day of the conference. Again, the timing will be the same, 10 a.m. So for that today's session, we will wind up the session. And thanks everyone for having patience and just listening to all the speakers properly. Thank you, everyone. Have a blessed day ahead. Hope to meet you people tomorrow exactly at 10 a.m. Good day.
Thank you, ma'am.
Thank you, everyone.